All right, we're set to go. Ladies and gentlemen, my name is Samar Zwelem. I'm the Associate Director of Research Department at King Khaled Eye Specialist Hospital. It gives me a great pleasure to welcome you all to this symposium titled Ocular Genetics. Um, I'm very pleased really to encourage to see many speakers, researchers, genetists from different backgrounds to join us today. I want to welcome our speakers who will deliver 14 presentations over the course of 4 hours and 30 minutes. Dr. Dominic Fisher can join us today. However, we have an alternative presentations which will be of a great interest to you. This symposium will start by an opening remarks by the CEO, a video, and then there will be 2 sessions. The first session will start soon until 3 p.m. Riyadh time. That will be followed by 20 minutes break. The second session will start at 3 p.m. until 5 p.m. Riyadh time. This symposium meant to be an interactive, therefore you are encouraged to participate and poll questions and to submit your questions in the Q&A box at any time. These questions will be entertained at the end of each session. Dear speakers, panelists, please mute your mics if you are not presenting, and a reminder will be sent to you when your presentation is about to come to an end. Our symposium have an accreditation by the Saudi Commission for Health Specialists. So a great reminder for you to fill out the evaluation form that you're gonna receive at the end of the symposium in order to claim the CME hours. Our symposium will kick off shortly and we'll start with the video.
Okay, can you hear me now?
Yes, we can. It's my great honor to pass the mic to the Dr. Abdelaziz Rajhi, the CEO of King Khaled Eye Specialist Hospital. Dr. Rajhi will present the opening remarks.
Well, good morning, good afternoon, actually, everyone, and thank you so much for being with us. You know, as it always happens, whatever can go wrong will go wrong. So my apologies for the little hiccups I had with my connection. It's a great pleasure to welcome you all. This is a very important meeting for us as we are trying to establish a more advanced services within King Khaled Eye Specialist Hospital in the area of congenital diseases. I see some familiar faces. Dr. Arif Khan, it's always a pleasure to see you, whether in person or virtual. And we thank you for your support for KKESH and all the scientific activities that always we conduct in your presence and with your support. I'd like to also thank all our speakers who are presenting with us today, those that are from KKESH, and our colleagues that are joining us from other parts of the world. We know that you have a very busy schedule, and we totally understand what time and effort you put to be with us. I'm sure that the rest of our speakers will join us probably later as they have their talks. Dr. Ten is a very dear friend from the Singapore National Eye Institute, and we all look forward to his contribution, as well as Dr. Arno and Dr. Abu Amro. It has been a pleasure to have you all. I welcome also all our attendees. I think we've had quite a good turnout, Dr. Samar. I heard that we had more than 780 participants so far.
Correct.
So this speaks for the great efforts that you've put and the very interesting symposium and presentation that we have had. So I don't want to take too much of your time. I thank you all for your support. I thank the organizing committee, the scientific committee, all of those that put the hard work and effort to making this possible in spite of all the difficulties that we have faced. And again, I welcome our speakers from outside KKESH, and best of luck.
Thank you. Thank you, Dr. Rajhi. Now the time for the video. I'm delighted now to pass the mic to the chairman of the first session, Dr. Sawsan Nawilati, and the moderator, Dr. Patrick. Please go ahead.
Good afternoon, everybody. Very happy to see you all, and thank you all for joining us. My name is Sawsan Nawilati. I'm a consultant in retina at the King Khalid Eye Specialist Hospital, and I'll be chairing this session. And my co-chair is Dr. Patrick Schatz, who is also from our department at the King Khalid Eye Specialist Hospital, who will be moderating this session. I'm really very, very happy and excited to join you all, and particularly I would like to welcome my colleagues and friends who have joined us and agreed to speak with us today. Our program today will start with the talk of Dr. Arif Khan. I don't think Dr. Arif Khan needs any introduction. He's a dear friend and a very well-renowned, internationally acclaimed known person in the field of genetics and eye genetic disorders. He's professor of ophthalmology at the Cleveland Clinic, Lerner College of Medicine, and a consultant ophthalmologist in pediatric ophthalmology and ocular genetics at the Cleveland Clinic Abu Dhabi in the UAE. And he was a past member holding a position of senior academic consultant in genetics and pediatric ophthalmology at KKESH. We welcome him dearly with open hearts, and we are very, very happy and looking forward to his first presentation. Genetic conditions of ophthalmologists should not miss. Dr. Khan.
Can you hear me? Yes?
Yes. Yes.
And you can see my screen.
We can see your screen, Dr. Khan.
Okay.
If you can raise your voice a bit, that would be great. And I'd like to ask you please to also signal, if you have poll questions, to signal to us when to display the poll questions during your talk, if you have them.
Okay, maybe we can do that later. Well, let me just say thank you so much. What a great pleasure to be here. Respected Chairman of KKESH, CEO of KKESH, Dr. Abdulaziz Al-Raji, chairs of this wonderful meeting, Summer Al-Suwailam, Amani Al-Bakri, Scientific Committee, Dr. Sawsan, Dr. Patrick, Dr. Suleiman. Thank you for putting this together and making it possible, and thank you for including me. It's really such a pleasure to be here. I wish I could be there with you, but this is the next best thing. I'm really happy to see this symposium, and I can't think of a title to begin it with better than this title, Genetic Conditions Ophthalmologists Should Not Miss. because this is something really core to ocular genetics. What are genetic conditions that ophthalmologists should not miss? Well, these are conditions that come to ophthalmologists first, typically without the diagnosis, and conditions for which an early diagnosis makes a difference. It decreases morbidity in the patients. These are the conditions that we should not miss. Now I have a time slot for this, so I've chosen some selected scenarios. I see most of this meeting is retina, so I've stayed away from retina. And I've tried to choose some conditions that typically are diagnosed by pediatricians or geneticists, but really we, the ophthalmologists, are the best ones to diagnose these conditions, and we shouldn't miss them. So I don't have any financial disclosures, and I've decided to cover 3 scenarios during my time slot. And the first one is exemplified by this child, a 4-month-old boy, the 4th of 4 children. The parents are not related. He is referred for nystagmus. You examine the child, you see he has no iris. That's not a pharmacologically dilated pupil. He has peripheral keratopathy, he has lens opacity, he has foveal hypoplasia. This is not a hard diagnosis for an ophthalmologist to make. This child has classic aniridia. But classic aniridia is not the genetic condition I'm worried about. When we have a child with new sporadic congenital aniridia, and there's no family history and it's a new baby, that sometimes is a marker for a genetic condition we should not miss. That is to say, a mutation in WT1. PAX6 sits on the short arm of the 11th chromosome, and a new deletion will cause a new case of congenital aniridia in a family. But sometimes these deletions are large enough to hit the neighboring gene and also cause the contiguous gene syndrome, Wagner syndrome. That is, knocking out WT1, the gene next to PAX6, will cause a propensity for Wilms tumor of the kidney and a risk for Wilms tumor 50% by 5 years of age. So a situation like this is one of the situations where I feel genetic testing is really indicated. And sure enough, when we do genetic testing on this child, we find he has a large deletion on the short arm of chromosome 11, knocking out PAX6, not surprising, but also knocking out WT1. And he does go on to develop Wilms tumor of the kidney a few years later, but we're following him closely and we're able to catch it. I think some people might have their microphone on, so if everyone can mute their microphone, then we won't have any background noises. So a few words about PAX6 classic aniridia. PAX6 is a master control gene that regulates genes required for the formation of the eye. When we knock out PAX6, we get classic aniridia, which we're all familiar with: keratopathy, lack of iris, lens opacity, et cetera, But something we should be aware of, that more minor mutations in the gene, missense mutation in the gene, can cause partial phenotypes. And that's something that we sometimes are not as aware of as we should be. Glaucoma is part of PAX6 related anterior segment disease, but it typically occurs later on. It's typically not congenital. And the genetic condition we shouldn't miss, a mutation that affects PAX6 and its neighbor, WT1, is typically a sporadic new deletion. And when WT1 is knocked out, you have a predisposition of Wilms tumor of the kidney, approximately 50% by 5 years of age. This cartoon just shows you where PAX6 sits on the short arm of chromosome 11. Right next to a WT1, you can see how a deletion would knock out both and cause a predisposition for Wilms tumor. We don't have the same concern when we have familial aniridia. When we have familial aniridia, obviously we have to deal with the eye disease. The eye disease is something difficult to deal with, but we're not concerned with this predisposition for Wilms tumor because the familial mutations are typically intragenic and they're not going to be affecting WT1. So we can breathe a little bit of sigh of relief for that concern when we have a familial case. I want to share with you this girl with congenital cataract and microcornea. Congenital cataract and microcornea has many, many different potential causes, and there's no way you can know the cause by looking at a child. But when we did genetic testing for this child, she had a missense PAX6 mutation. Again, minor mutations in PAX6 can cause partial phenotypes, and anything that you know is as part of classic aniridia can be caused, can occur in isolation from a minor PAX6 mutation. Here's a boy with nystagmus and idiopathic foveal hypoplasia. He was actually being worked up for albinism by another clinician, which is reasonable because, of course, a foveal hypoplasia is part of albinism. But when we look at him more closely, what do we see? We see he's got a partial optic nerve hypoplasia. When we examine his anterior segment, he has a peripheral keratopathy. He does not have lack of iris. But these features, foveal hypoplasia, optic nerve hypoplasia, peripheral keratopathy, even though there's no aniridia, it's screaming at us, PAX6 mutation. And sure enough, this child has a missense mutation in PAX6, a partial phenotype. I want to share with you this girl with albinism and unilateral cataract who's referred because of failure to wear her aphakic contact lens. She was referred for secondary IOL implantation. Here she is. She has albinism, and she also had cataract for which she had lens removal. She also has capillary hemangioma and eczema. But when we examine her, she also has lack of iris. Why does she have lack of iris? That's not part of albinism. And in addition to that, why did she have cataract in the first place? That also is not part of albinism. This needs further investigation. We examined the family. Her brother has classic albinism. We find the mutation causing albinism, but that's not the end of the story. Why does she have lack of iris? Why does she have cataract? We look at the short arm 11th chromosome. There's a large deletion there. And sure enough, it's hitting WT1. And this child also has a Wilms tumor that even an ophthalmologist can palpate through the abdomen, which had been missed for so many years. So I've shown you now that Wagner syndrome is a genetic condition we as ophthalmologists uniquely can pick up and should not miss because of the ability for us to decrease morbidity in these patients. My next scenario is this child with corneal haze sent for glaucoma surgery. I don't have pictures of the corneas to show you, but I do have pictures of the face. And when we looked at the face, it brought up a particular consideration. So we asked some further questions. And sure enough, this child has a history of recurrent upper respiratory infections. The child has joint laxity. This child has the facies and the features of an undiagnosed mucopolysaccharidosis. And these facial features are the result of glycosaminoglycan deposition in the cornea, in the soft tissues. And the corneal haze is the result of glycosaminoglycan deposition in the cornea. Now, these children can get glaucoma, but they don't get glaucoma as babies. They could get glaucoma later on. Some sets of mucopolysaccharidosis just get a corneal haze. And this is something we as ophthalmologists need to be on alert for, because these patients can go for years without a diagnosis when their findings are subtle. And here's another child who's referred as glaucoma who actually had an undiagnosed mucopolysaccharidosis. No glaucoma, it was corneal haze from deposition. And here's another child, the same thing. This happens in the region. Be on alert for mucopolysaccharidosis. Mucopolysaccharidoses are a group of lysosomal storage diseases, and there's about a dozen of them. They're defined by the specific enzyme that's sufficient. We don't have to go into those details. They often have characteristic facial features, those coarse features that I showed you in those children. Corneal clouding is a recurrent manifestation in many of the subtypes. They can also get glaucoma, but it's not a congenital glaucoma. If they get glaucoma, it happens later on. Systemic manifestations are related to this deposition of material in different tissues of the body. And it is important to pick these children up early because there are treatments depending on the subtype. And the earlier they're picked up, the better. And when it involves the eye, there's nobody better than the ophthalmologist able to pick up these patients early and get them treated appropriately. Children with obvious severe mucopolysaccharidosis are not hard to see. It's clear that there's something wrong. But there are subtle cases that can go years without diagnosis, and sometimes they're never diagnosed. As Dr. Sousen introduced me, I'm a pediatric ophthalmologist, but I do get referred adults who seem to have genetic conditions. And here's a 33-year-old male who was seen because of burning eyes and referred to me by one of my colleagues. And here he is, and he's got short stature, sensory neurohearing loss, obstructive sleep apnea, asthma, bilateral carpal tunnel syndrome. These are all manifestations of storage disease. This gentleman has been going for over 30 years with his mucopolysaccharidosis without a diagnosis because nobody is putting these things together. We as ophthalmologists really need to be attuned to this diagnosis. This is a nice paper that came out in one of the journals that talked about clinical hints for diagnosing attenuated mucopolysaccharidoses. And very, very high on the list is corneal clouding. Any patient who comes to us with corneal clouding, even adults, we have to consider the diagnosis of mucopolysaccharidosis. There are attenuated forms. These patients can benefit from treatment, but their benefit comes if they're treated early. The last scenario I'll share with you is illustrated by this 3-year-old girl referred for low vision, nystagmus, and abnormal head position. You examine the child and you find that the child has albinism, oculocutaneous albinism. And you can even see that she's more lightly pigmented than her brother who's sitting next to her but is not in the picture. But we're not done. We have to ask some pointed questions, especially in this region of the world. And when we ask this child, when we ask the mother about easy bruisability, this child bleeds all the time and gets bruises all the time because this child has an undiagnosed Hermansky-Pudlak syndrome, a bleeding diathesis. Hermansky-Pudlak syndrome is the most common albinism syndrome we see in this region. And these patients, besides their bleeding diathesis, they have a risk for organ fibrosis. Important to pick these children up to minimize morbidity so they get the appropriate follow-up and the appropriate management for their bleeding diathesis. Here's another girl referred for low vision. I think we can all see that she has clear oculocutaneous albinism, but we're not done yet. When we ask the question, she's bleeding all the time. She has undiagnosed Hermansky-Pudlak syndrome. We see a lot of it in the region. Actually, I was shocked when we studied it, how frequently we saw children with albinism who had not been diagnosed, had mutations in Hermansky-Pudlak genes. We need to be aware of this condition in the region. A few words about albinism. Many different genes can be mutated to cause albinism. There's an ocular form only, which is X-linked. There's an oculocutaneous forms. Obvious cases are obvious, but there are a lot of mild cases that go undiagnosed, and we have to be attuned to that because if we don't pick them up, nobody else is going to pick them up. Rare syndromic forms occur, especially in this region, but Hermansky-Pudlak is the one that we really have to be aware of. These children, we don't tell them there's nothing to be done. Even if they don't have a systemic diagnosis, if it's isolated albinism, they need sun protection, refraction, and sometimes strabismus surgery. Again, none of us is going to miss an obvious case of albinism. It's very clear when they're white, very white, they have transillumination, and they have hypopigmented fundus. But let me tell you, there are a lot of subtle cases going around that go undiagnosed. Here's a girl with nystagmus and low vision, referred for idiopathic low vision. She hadn't had an ERG before she saw me. She had had an MRI before she saw me. But when we examine her and look very carefully in a dark room, we can see the iris transillumination. Any child who comes in with nystagmus and low vision, look for that iris transillumination. There is such a variability in the albinism presentation, and sometimes they don't look that lightly pigmented in terms of the skin. Here's a 14-year-old boy with nystagmus and low vision. He had also been through the MRI. He had also been through the ERG. He also had some mild iris transillumination, but there's a very cheap test that we can do that brings out the diagnosis very quickly. When we take a pedigree, he clearly has an X-linked disorder, and this is X-linked ocular albinism. And to further prove the point, when you're suspecting X-linked ocular albinism, take a look at the mother, and sure enough, the asymptomatic mother had this appearance. It's sometimes called the mud splattered appearance. streaks of hypopigmentation. It shows up a little bit better on the autofluorescence. She's a carrier. So this brings me to the end of my talk. I've gone through some genetic conditions ophthalmologists should not miss. The thread that ties these conditions together is that they often present to us as ophthalmologists first before the diagnosis is made. And making the diagnosis makes a difference in the patient's morbidity. Thank you so much again for having me, and thanks for your attention.
Thank you very much, Dr. Arif Khan, for this excellent lecture, which we all enjoyed very much. The next speaker is
can we put the poll questions now, if there's any?
Okay.
Now, the first poll question is going to be answered in my second lecture, in a later lecture, because the schedule was rearranged a little bit. But you can try to answer it. But the second one was obviously covered by this talk, so you should still get the first one. But I didn't cover it because it's going to be covered in my next talk. But please go ahead with the poll questions. A child with apparently isolated lens subluxation who has not undergone genetic evaluation. I didn't cover that, but I'm covering that later. Should have surgery immediately, might have later aortic root dilatation, does not need genetic assessment, is a suspect for later kidney failure. The second question, which I did cover, a newborn with congenital aniridia is born to healthy parents. He's at most risk for later Wilm tumor of the kidney if A, the gender is male, B, if there's coexisting glaucoma, congenital, C, if the delivery was premature, D, if the baby is an only child. Okay. Do I answer these also? Came to me. I'm going to answer it.
Okay. Should we proceed with the
Okay, well, the first one, it looks like people are well attuned to what's being alluded to there. And even though it says isolated lens subluxation, the answer is B. It is a suspect for later aortic root dilatation, and I covered that in the afternoon. But this one, the newborn with congenital aniridia, born to healthy parents, is at most risk for Wilm tumor of the kidney. No, the answer is D, because it's the sporadic aniridia that's at risk for Wilm's tumor. And usually congenital aniridia from PAX6 mutation does not have congenital glaucoma. You can see congenital glaucoma with aniridia, but that's typically not PAX6 mutation. So the answer for 2 is D. We're more worried when it's a sporadic case. Thanks.
Thank you very much, Dr. Arif Khan. Next speaker is Dr. Rola Baabad. She is a new consultant in KKESH, but she has an extensive experience from ocular genetics, amongst others from Moorfield and also from Canada. So let us welcome Dr. Rola Baabad to give the next presentation.
Thank you very much. Good afternoon, ladies and gentlemen. Can you hear me? Yeah,
yes.
okay.
Yes.
So it gives me great pleasure to actually present this forum. I'm sharing my screen now. Okay, so I've been asked to fill in for Professor Fisher, and I thought this might actually summarize what I witnessed since I left KKESH in 2008. And this is an experience that I carried on with me, seeing not only from this perspective of a clinician, but also from a perspective of somebody who attended clinics where actually there were quite a lot of questions that haven't been answered. And then the evolution of the technology of molecular genetics has helped tremendously in actually solving quite a lot of mysteries and uncovering interesting conditions. So I have no disclosures. I'm going to talk about how the service has evolved over time. And we're going to talk about genetic testing. So basically, there has been quite a lot of milestones and paradigm shifts starting from the 1990s. And you can see in the blue, actually, so you can see here the timeline, and with the blue, actually, the loci for genes that have been mapped over time, and you can see the accelerated increase in number of the genes identified as you can see the technology evolved. So from the discovery of rhodopsin as the cause of autosomal dominant RP using Sanger sequencing and candidate gene approach and linkage analysis, then the human genome sequence was completed. And after that, the evolution of whole exome and whole genome sequencing has actually allowed quite a lot of discoveries to take place. And now I think we are reaching some sort of a bottleneck now that most of the candidate genes, especially expressed in the retina and involved in the phototransduction cascade and the visual cycle, and even the retinal first synapse between the photoreceptors and the bipolar cells, most of those genes and pathways have been discovered. So we are moving into a next stage where more discoveries are being made, but they are actually at a much slower and smaller rate. So the candidate gene testing started shortly after the evolution of actually the Sanger sequencing, which interrogates the gene of interest. So you identify, say, for example, the main opsin in the photoreceptors, and then a candidate gene becomes apparent to you, like the rhodopsin in the rods and the LNM opsins in the cones. And therefore, especially the dominant disorders actually took precedence, like rhodopsin and PRPH2, which is RDS preferrin. But then after that, the most common genes started to actually it became apparent that actually some recessive disorders are more common in certain populations, and then the search and identification of those genes like ABCA4 became a reality, and ABCA4 is a never-ending story, and probably as Dr. Gavin Arnold gives his talk, he may actually touch upon the missing heritability in ABCA4, which is still a hot topic. Obviously, the most common genes like RPGR, the X-linked retinitis pigmentosa gene, and later on identification of open reading frame 15 as the hotspot actually has solved quite a lot of previously unsolved cases of X-linked retinitis pigmentosa and cone rod dystrophy. So limitations of Sanger sequencing are many, I mean laborious obviously, and the extended number of genes, if you check on RetNet, you will notice that there are more than 200 genes that are associated with retinal disorders alone. And one limitation also is that ABCA4 is a huge gene. So imagine sitting and sequencing an individual for actually biallelic mutations in this gene is going to be a rate limiting factor when it comes to reaching a molecular diagnosis. And then came the next generation sequencing, and it offered quite a lot of advantages. It's unbiased, basically. It has high throughput, and it uses different platforms. And with the introduction of next generation sequencing techniques, new genotype phenotype associations, and quite a lot of discoveries and surprises actually, including as Dr. Arif Khan has just recently touched upon, the variability between hypomorphic alleles, for example, and say, for example, severe mutations that can cause the full-blown picture of mucopolysaccharidosis. And sometimes these hypomorphic alleles wouldn't be suspected immediately, and therefore actually having an unbiased technique is going to answer a few questions, but also give you quite a few surprises. Also, the discovery or the introduction of next generation sequencing also has actually allowed us to glean into genetic disease mechanisms, because once you identify a pathway and then you can actually find out that there are certain disorders that have a common phenotype, like for example, the complete type congenital stationary night blindness, and this can mechanistically lead you to actually discovering several genes along the pathway. Obviously, I mean, the most of the audience is well versed in the types of genetic variants that we encounter, the missense changes that are still sometimes pet peeves, especially the novel ones, and the variants of unknown significance actually are sometimes difficult mysteries to solve, and that highlights also the importance of sharing data internationally. But then obviously the obvious ones like the nonsense and frame shift mutations and the splice site variants, and sometimes synonymous variants can also affect the protein in different ways, and one of them is actually introduction of aberrant splice sites. Obviously, the ABCA4 is still riddled with, given the large size of the gene, it's still riddled with quite a few intronic variants that are disease-causing. And then, again, the advancements of the technology has allowed us then to identify more of the structural variants that can solve quite a few of the unsolved cases. So I'm not gonna dwell on this, probably this can be given at a basic science lecture, and obviously one of the things is that when I mentioned the missense changes and the variants of unknown significance, this, I mean, the massive amount of information and data that became available has called for actually more of an international consensus on how you can classify the variants according to the American College of Medical Genetics criteria. And this is the basis of actually a new career that developed, and career pathways that developed in bioinformatics to actually help the clinicians and the clinical geneticists in deciding which variant is likely to be disease associated. The introduction of large whole exome and whole genome population-based data actually has offered us also a unique opportunity to compare the data from a patient. So previously, if you look at the old publications, they would say that this particular variant has not been found in you know, in-house data for, say, for example, a couple of hundred individuals. But now we are talking about much larger size databases that actually allow us still to actually compare how rare the variants that we are considering compared to the population. Obviously, the more rare the variant is likely to actually add to the weight of actually whether to consider it as disease associated or not. And this has been quite a feat that has been introduced just in the last couple of years. This is also ClinVar is a public database that is accessible, and we encourage everybody to actually submit their data there for the knowledge of others and sharing knowledge. And obviously the introduction of in silico tools that can actually check whether actually this particular missense change might have an impact, at least theoretically, on the protein from conservation data and other aspects. So all of these tools became available to us. This is something that I witnessed practically from the 1,000 genome data and database, and then the introduction of Exact, and later on the introduction of Nomad. I mean, it was a great pleasure actually witnessing these milestones developing. And obviously, this is one of the papers that Dr. Gavin Arno made the genetic discovery, and we put together actually the interesting phenotype, and we actually happened to be in a position to refine the phenotype, seeing two unrelated patients with variants in CACNA2D4. And we managed to actually refine the phenotype and saying that probably it is not a bona fide incomplete CSMB, as has been thought before, and rather actually this is a condition that mostly affects the cone system function. And the use of in silico tools like that allow us to visualize the next generation sequencing data like the IGV has helped this particular discovery because of the large deletion that you can see here. It shouldn't be missed. And it was homozygous in the proband. So moving on to also another milestone that has become possible because of the introduction of the new technology, which is solving previously unsolved cases. And this is an example of the fundus photo for male in his mid-40s who presented dramatically as rapid loss of vision and hearing loss. And the patient was adopted, so we didn't have any information about his family at all. And it was really a panicking situation because the dramatic presentation alerted the physicians and the ophthalmologist to refer him for screening for carcinoma-associated retinopathy. Given the dramatic presentation, and then when no neoplasms were found or cancers, the diagnosis was revised later on as autoimmune retinopathy, and it was sort of an unsolved mystery for years. This is later on, you can see that more atrophy has become apparent now along the vascular arcades. And also there is some vascular closure in the periphery, signifying quite a lot of visual and retinal damage. And actually at this stage, the full field ERG was completely undetectable. And adding to the dramatic picture, actually, despite that you don't see much pigmentation in the retina, there is quite a lot of loss of the autofluorescence signal in the posterior pole specifically, and also in the mid-periphery of the retina. So this is again one of Dr. Gavin Arno's discoveries, and this is basically a complex deletion, inversion, and insertion, actually. And if it wasn't for the new technology, I mean, this patient has been waiting for a definite diagnosis for quite a while until actually this has been detected, given that the patient has entered the genetic studies. So sometimes, you know, having high technologies can produce quite a lot of data that we find quite challenging to sift through, but finding such unique presentations and unique variants in a relatively new gene. Actually, CEP78 has been just recently described as associated with severe cone rod dystrophy and hearing loss only in 2016. So this was a feat of the advancement in molecular genetics. And this is the discovery paper at the top. At the bottom is actually the complex structure variants paper in which this patient particular case was described. So also we know that, say, for example, Usher syndrome is caused by, you know, you have type 1, 2, 3, and so on and so forth, and several genes associated. But it became truly interesting when certain variants in known genes that are associated with syndromic retinopathies became actually candidates in conditions where non-syndromic retinopathies are the presentation. And again, I mean, if you don't do the genetics, you wouldn't suspect it, and the patient goes around unsolved. And interestingly, 2 of these genes on my list are actually associated with the much more severe neuronal ceroid lipofuscinosis. And it gives actually patients and the physician a relief, actually seeing that this patient has retinopathy, and then the genotype has been solved, and these genotypes are specifically associated with non-syndromic retinopathy. So you can reassure the patient to a certain extent. Obviously, you need long-term follow-up, but in those patients, usually they don't develop syndromic manifestations. So it gives you the certainty and the assurance both for the treating physician and the patient when such diagnoses are being made. So one of those also feats have actually allowed us to identify a relatively rare genotype in a patient who presented initially and was told that she's got retinitis pigmentosa, and she was going around for decades under the impression that she's got retinitis pigmentosa. But these are not features of retinitis pigmentosa. Usually in RP, when you lose the photoreceptors, actually the retinal pigment epithelium climbs from within from underneath the retina and actually settles in the inner retina, in the retina in general. But these are deep retinal pigmentations, and these are clumps of pigment, much unlike what you see in patients with retinitis pigmentosa. And you'd think to yourself, okay, could this be a female, very severe, particularly severe case of carrier state of choroideremia? And this indeed the question that was answered in the beginning, and the answer was no. But then you trace other family members and you can see these kind of reticular changes at the level of the RPE more apparent on the autofluorescence in several family members, including two asymptomatic excuse me, family members of this particular family. And again, you wouldn't suspect, you know, a list of particular genes that affect the retinal pigment epithelium before it affects the photoreceptors. You screen the patient for those genes, and again, candidate gene testing wasn't the answer in this case. So actually, and this is the family. Excuse me. And you can see in the family here that actually it's, although you don't see any direct male-to-male transmission, you'd think, you'd consider dominant inheritance. And we happen to identify also from our communication another family from West Virginia. Again, similar features. And also dominant inheritance, and this is also gives you assurance to see that actually there is male-to-male transmission here, so it's unlikely to be X-linked. And actually, we discovered that both families carry a particular mutation in the gene RGR, which encodes for a special opsin that is expressed in the retinal pigment epithelium. And we did haplotype analysis, and indeed the two families unknowingly are related. So again, if it wasn't for unbiased clinical genetic testing, probably those two families would have been missed for years without an answer. So there are still some uncharted territories that are quite exciting to explore in the future, and there are more avenues to explore. And that includes also the role of trans alleles in variable penetrance and expressivity in dominant disorders, the cis-acting elements, and you know, the more we actually see the phenotypic heterogeneity, we can understand more about the mechanisms of even particular mutations in genes that we already know of. And then this can lead us, this understanding can lead us to exciting advancements in novel therapeutic approaches. We're going to hear later on about gene therapy, but gene replacement is not the only way forward. There are other ways that act mechanistically, such as optogenetics or inhibition of RPE65 in patients with ABCA4 retinopathy, and antisense oligonucleotides for treatment for particular intronic changes in patients with CEP290 retinopathy. So in summary, I witnessed during my training career in more fields and in Toronto a shift from targeted gene testing to NGS, and later on the 100,000 genome study in the United Kingdom. I witnessed also the introduction of the gene therapy for an approval from the FDA and NICE for RPE65. the analysis for structural variants became part of clinical testing in some laboratories, and the shift in genetic testing from research-based projects to actually clinical standard testing, which will enable us to offer patients closure in quite a lot of cases to their questions. And obviously, these techniques have actually allowed the discovery of several genes. Thank you very much for your attention.
Thank you very much, Dr. Rola Ba'abad, for a very nice overview and a dense lecture indeed. So we will, because we're running short of time, we're going to keep the questions to the end. So I would like to welcome now Dr. Abdul Ilah Al Abdullah, who is a consultant ophthalmologist at the Vitreoretinal Division at the King Khalid Eye Specialist Hospital, and he will talk to us today about characterization of patients with inherited retinal diseases using a hospital-based genetic registry in Saudi Arabia. Dr. Abdul Ilah.
Assalamu alaikum. Bismillah. It's really my pleasure to join you in this afternoon talking about the genetic registry. And I would like to thank the chair, the co-chair of this session, and Dr. Samar, Dr. Amani for their kind invitation to pursue this talk and this forum. So initially, I would like to thank also the participant and the Retinal Dystrophy Registry Group, the fellow, the resident, our colleagues, especially Dr. Naziha Zaidi, who contribute significantly in cleaning the data, and Dr. Amani, Dr. Khabir, Dr. Patrick Noelati for their initiation of this registry. So basically, this is an ongoing work based on the hospital-based genetic registry that established recently. And we will talk about the feature, a clinical feature and genetic feature of the group of patients that we are investigating. So basically, genetic registry is it is collection of the data and pulling the data in one place, so that will help you in characterize the patient from the clinical point of view and also from the genetic point of view. In addition, that might help you recruiting patients in future therapy or clinical trial. So we are describing the first 650 patients in this presentation. So the important thing in the clinical feature, you will notice that the age of patients are usually younger than what we see usually in the retinal clinic, with median age of 23 years of age. And symptoms usually start early on in the first 12 years of age in the majority of patients. And the symptoms usually reduce vision, poor night vision, nystagmus, and usually gradual progressive disease in the majority. However, some patients are having stationary or stable reduced vision from the beginning till the end. And this is really important to emphasize for the fellow resident that handling a young patient with ocular disease that causing visual disturbance, visual impairment, this is very important to recognize the difference between them than the adult category. Because we are handling young patients, there is sequelae to this disease on their education, their future career, future marriage. And we are talking about young patients with young family, with the parents are, most of the cases, also young. So that also will put them in a dilemma. What about the next children? What will happen? How can we avoid this in upcoming pregnancy? And this is really important to recognize when you handle such patients. So in our registry, the male represents like 60%, 40% female. And this is quite interesting because other poll data showed similar presence of the both gender. However, are we dealing with more X-linked disease, which present in more male in our data, which I doubt it, basically, or is there an access to care issue? This is something we need to think about or investigate further. When we talk about family history and genetic disease and retinal dystrophy patient, you will notice that the consanguinity is very high. So it's ranging between 40 and 60, depending on the definition that you are using. However, this is not surprising. Other study also, a local study showed up to 78% of the consanguinity in our community. And as a result, inherited retinal dystrophy is a significant cause of vision loss in young patient and adult patient in the kingdom, with the sequelae on the quality of life and the health economics as a result of the social construct and how people are managed, the intrafamilial marriages and so on. So what are the patterns that you will see in the retinal dystrophy with inherited retinal diseases? By history, you can figure out that the majority of patients are autosomal recessive. However, this is confirmed also in the genetic testing with 74% result as autosomal recessive. The autosomal dominant and X-linked by history and the genetic testing is less frequent. So most of the patients are presented with isolated ocular disease only, and this can be seen in the 85%. The remaining are coming with syndromes like Bardet-Biedl syndrome or Usher syndrome with other symptoms rather than the ocular impairment itself. When we come to the clinical diagnosis that made in the clinic, basically the retinitis pigmentosa will be the common sort of presentation and diagnosis that was made based on the investigation, the examination, the investigation, and electrophysiology as well. Conrad dystrophy, Leber congenital amaurosis, Bardet-Biedl syndrome, and other are less frequent, however, they are present. And this is, you know, the list is not complete here, but this is showing you basically the clinical heterogeneity that we have with different disease, inherited retinal diseases affected different parts of the photoreceptor, basically. Some of them are affecting the cones, some of them are affecting the rod, some are mixed, some causing macular diseases, some causing generalized disease, some clinical feature coming with like stationary non-progressive diseases, and we have other entity that progress in the, within the patient, basically. And the genetic testing has been covered already, but among the patients that we have in the registry, 40% underwent genetic testing, and usually they underwent multiple gene testing, what we call it panel testing. However, single gene also been requested less frequently. This is, you can request it when you are pretty sure that this is what you are handling. For example, if you are handling a feature with pathognomonic feature and you are suspecting this is the mutation that you are looking for, you ask for a single gene testing. However, whole exome sequence can be the solution to figure out the genetic mutation in certain patients. However, it was been requested less frequently. Whole genome sequences have been not requested in the registry data. And pathognomonic and likely pathogenic mutation were recognized in 80%, and as you can see, we have 20% of the cases were not resolved, and the remaining was resolved as autosomal recessive, and the 74% of the patients, and 4% and 2% in the autosomal dominant and X-linked mutation. So if you look at the mutation themselves, in the registry, we recognize there is more than 70 genes involved in the inherited retinal disease that we are handling. Basically, there is a lot of gene involved, different mutation as well within the gene, and this is showing you basically again, the genetic heterogeneity that we are handling. For example, we are handling ABCA4 that is affecting macular disease dystrophy, RB1 retinitis pigmentosa, and the list goes on, basically. So in conclusion, the initial analysis of our registry showing the heterogeneity of both the clinical feature and the genetic result of this pool data. And hopefully this will help us in future in-depth analysis of certain phenotype and genotypically isolated cases. Thank you very much.
Thank you very much, Dr. Abdullah, for this informative presentation of the KKESH Retinal Dystrophy Registry. I don't know, Dr. Samar, if we have any poll question now. Okay.
Yeah, basically the first question is concerning the consanguinity. Do you think it is a significant contributor in the inherited retinal disease or inherited ocular diseases as well in Saudi Arabia? So the answer is either true, false, maybe. So you can pick one of them. So I think most of you will answer them. So the second question is main clinical phenotypes among retinal dystrophy in Saudi Arabia based on clinical feature. Is it retinitis pigmentosa, or is it Cone dystrophy or Conrad dystrophy, or liver congenital amaurosis, or is it Bardet-Biedl syndrome? What do you think the most common clinical phenotype that we are seeing in the retinal dystrophy clinic? I think my question, either it is very simple or the lecture was very clear, and this is the consanguinity. Yes, true, it is a significant contributor in the inherited ocular disease in Saudi Arabia. And the second question is mainly retinitis pigmentosa that we have. I think that's indicate a very good understanding of my talk. Thank you.
Thank you very much, Dr. Abdullah. Next speaker is the chair of this session, Dr. Sausan Novilati. Dr. Sausan Novilati, she is a senior academic consultant at King Khaled Eye Specialist Hospital, and she will give her talk now about the spectrum of familial retinal arterial macroaneurysm syndrome.
Thank you very much.
Dr. Novilati, most welcome.
Thanks, Patrick. And thank you, everybody. I'm sharing my screen and I will start the slideshow. Just please reassure me that you are seeing my screen and my full slides. Do you see my full slides?
We can see it very well.
Very well. Okay, I would like to get this down here. Hold on. Hide. Just bear with me, please, for a moment. Okay, here we go. So, good afternoon again. And again, I'd like to thank you for inviting me for this wonderful meeting. My talk today will be about the spectrum of familial retinal arterial macroaneurysm syndrome, which is I'm happy to say, is a KKESH-born entity. I have no financial interest to disclose. And I would like to start with the poll. Majid, if you could please put the poll, and I will go through it. And the reason I'm putting this poll now is because I would like to know, since we have international audiences, how familiar is the international audience with this syndrome called familial retinal arterial macroaneurysm. So the questions are, A, I have seen patients with this syndrome. I readily recognize its phenotype and know the features that differentiate it from other retinal conditions. Or B, I am somewhat familiar with this syndrome, but I don't always know how to differentiate it from other conditions. Or C, I have vaguely heard about this syndrome, but don't recall its features. Or 4, I have never heard of this syndrome, and I'm curious to learn about it today. And since Okay, the second poll, you can forget the second question because this comes out later. We'll forget the second question because this comes in later. So can we have the answer for the first question, please? Okay, so some people answered already the second question, and there are about 38 people, 38% of the audience that have never heard of the syndrome. So this is good news because we will hopefully familiarize you with this syndrome. And I will close this for now, and we'll talk about the syndromic conditions in a moment. Okay, so some background first. In 2002, my colleagues, Dr. Hardeep Dinza and Dr. Aboud at the King Khalid Eye Specialist Hospital described a novel entity in 6 young patients from 3 unrelated families who had aneurysms of the retinal artery with recurrent episodes of leakage and bleeding. They called it familial retinal arterial macroaneurysm, or FRAM for short. Now, as additional patients were seen, I'm having a hard time. There we go. As additional patients were seen, the genetic and the systemic exploration permitted to define and to establish FRAM as an autosomal recessive condition caused by a founder splicing mutation in the insulin-like growth factor binding protein, which is now called angiomodulin. In addition, many patients were discovered to have supravalvular pulmonary stenosis. So the term evolved from FRAM in 2002 to more recently retinal arterial macroaneurysms with supravalvular pulmonic stenosis syndrome. Now, unfortunately, FRAM remains under-recognized because it is rare. It's not been reported outside of Saudi Arabia, and the phenotype can be confused with Coates disease or Irvan syndrome by ophthalmologists that are not familiar with this condition. Yet it is important to recognize FRAM because it's not only vision-threatening, it is actually life-threatening. So the objective of my presentation today is to familiarize you with FRAM, or RAM-SVP as we call it now, and by describing the retinal phenotype and the natural history, the systemic associations, and also help provide management recommendations for the retinal and systemic pathologies. So we have studied over 31 patients with FRAM at the King Khalid Eye Specialist Hospitals, and males and females are equally affected, and patients generally present through their second or third decade of life, so rather young patients. All had the founder mutation in the angiomodulin, and all had this complete ophthalmic evaluation and systemic evaluation. Let's look at these ophthalmic features of FRAM. The hallmark of FRAM is retinal arterial beading and macroaneurysms along the major retinal arterial trunks, which are usually bilateral. Here you can see 2 examples of beading of the retinal artery as it exits from the optic nerve head, and the fluorescein angiogram demonstrates this beautifully. Here's another example of retinal arterial beading of the proximal portion of the central retinal artery, seen both on the color photograph and also on the fluorescein angiogram. That same eye also shows macroaneurysms along the retinal artery. I hope you can see them. I've highlighted them here in green. And the fluorescein angiogram often discloses the tiniest microaneurysm, which can escape clinical detection, such as we see here or here. Now, aneurysms can be isolated, uncomplicated, as you can see here, as reddish bulges along the retinal artery, or fibrosed, seen as whitish bulges, right there, which usually occur after an episode of either a leakage or exudation. This aneurysms can also be surrounded by intraretinal lipid or exudation, as seen in this slide. Persistent remnant of the hyaloid artery is present in 90% of patients, usually behind the lens, as seen here, and sometimes next to the optic nerve. Segmental arterial narrowing or sheathing is common. Here we can see it. And I would like you to notice also the arterial beading, the macroaneurysm, and the sclerosed or fibrosed macroaneurysms. Coates-like features are seen in 40% of patients, including saccular dilations and peripheral retinal capillary non-perfusion. Here's an example of a case with extensive peripheral retinal capillary non-perfusion. Notice that on the color photos, you can see the fibrosed aneurysms and the sheathed arteries, and on the fluorescein angiogram, this fibrosed aneurysm arteries are not visible because they are occluded, and you can see just an area of big capillary non-perfusion. submacular gliosis is seen in a third of cases, usually after an episode of intraretinal bleeding or exudation, and exudative retinal detachment is seen in about a quarter of cases when there is extensive macroaneurysmal leakage. Now, the natural history of FRAM is marked by recurrent episodes of macroaneurysm leakage and exudation, which usually respond nicely to photocoagulation, although sometimes we need to apply several times the laser photocoagulation. And it's also marked by episodes of bleeding from the aneurysms in more than half of the cases, and these episodes occur at any point in time and within or outside the macula and can lead to gliosis. Here's a case who had macular exudation from leaky macroaneurysm. Laser photocoagulation was applied to the aneurysms as seen here. Now, in the follow-up, the exudation decreased, but a year later it recurred and the aneurysms are larger. Laser was applied again, and 2 years later, the macular exudates are gone, the aneurysms have sclerosed, but new exudation is seen nasally, and laser treatment was applied again, and I attract your attention to the superior macroaneurysm, which 3 years later, as you can see, is much larger and is leaking into the macula. The nasal exudation has regressed, as you can see, but the macular exudation has increased. Laser was applied again to this macroaneurysm, and following laser treatment, the aneurysm decreased in size, but the exudation resolved. But now notice that this small which used to be a small macroaneurysm is now bigger compared to what used to be here. And here 4 months later, this aneurysm is larger, leaking. Other aneurysms are bigger and leaking, and there's an exudative retinal detachment here. So recurrent episodes is very common. Here's a case in which 2 macroaneurysms bled. The infranasal macroaneurysms were treated with laser, and 2 years later, both macroaneurysms appear fibrosed, which is usually the case after an episode of bleeding. But notice the small macroaneurysm superiorly. 6 months later, it suddenly bled into the pre-retinal space and into the vitreous cavity. And despite the initial resolution of the hemorrhage, 9 months later, there was a massive hemorrhage that required a vitrectomy. This was performed, and following the vitrectomy, those macroaneurysms are now fibrosed with arterial sheathing and narrowing. And here is a larger picture that you can see the arterial narrowing as a consequence, the arterial sheathing also as a consequence, and the fibrosed macroaneurysms. Macular gliosis, here is a case that happened after bleeding, and you can see in the follow-up how the sheathing has occurred along the vessels, narrowing of the vessels, and gliosis in the macula. Now, the dilemma with FRAM, for people who are not familiar with it, is, is it Coates? And usually the diagnosis of Coates or IRVAN is posed. But Coates is usually unilateral. In general, there is no arterial beading, and the aneurysm dilation is distal. And another differential is IRVAN, but in FRAM, there is no vitritis, and there's no vasculitis or scene of inflammation. Even if you do a fluorescein angiogram, the optic nerve does not light up, and there is no real CME. In general, the diagnosis is settled by genetic testing. It's important just to remember FRAM as a possibility in the differential diagnosis of these 2 entities. Now, let's look at the second question in the poll. And so what are these systemic involvement that I was talking about in FRAM? Which one is true? It is, first of all, question 1, it is limited to supravalvular pulmonic stenosis, hence the recent change of name from FRAM to RAM-SVP, or it is limited to cardiac valves in which supravalvular pulmonary stenosis is the most common, or it is limited to the heart, or it affects any major artery. Majid, could you please put the results of the poll again? Because people have answered already. Could we see the results? All right. So now please put this back. You had it for a moment. Yes. So basically the poll says 48% are saying that it can affect the coronary artery and cerebral aneurysms. And actually that is true. This is true. Let me see if I can advance this. It's not advancing. I'm unable to share this. All right, so that's what are the systemic features? Now, the cardiac morbidity is really significant in FRAM. It's 3/4 of the patients who had echocardiography had pulmonary valvular or supravalvular stenosis in 80% of them. Now, aortic supravalvular stenosis was coexistent in 26% of them, and 13 patients, young patients, required cardiac surgery. 13 out of 31, that's a lot. And 3 unfortunately died because of cardiac complications. But that's not all. Myocardial infarction at the age of 29 was seen in one female patient. She had left descending coronary artery stenosis and osteocoronary aneurysms, as you can see here. And you can see that these resemble really very much those, the arterial retinal narrowing that we see in retina. Now, her polyangiogram showed also subclavian artery occlusion, renal artery stenosis, mesenteric artery irregularities, and aortic involvement. So she was presumed to have Takayasu disease, but when she came to me, and this was 14 years afterwards, this is what we saw. We saw the macroaneurysms along the major retinal arteries, as you can see here. Even on the fluorescein, you can see the intraretinal hemorrhage and the lipid exudation right there. The beading of the retinal artery on the fluorescein angiogram, the sclerosed macular aneurysms and the sheathing, the segmental arterial narrowing, not very clear clinically, but perhaps more seen on the fluorescein, the persistent Cloquet canal right there, the RPE hyperplasia and the gliosis, the Coates-like features, and the intact venous tree. So basically the full spectrum of FRAM, and this is what we suspected to have FRAM, and we asked for genetic testing, and this indeed confirmed the diagnosis in the angiomodeling. One patient in our group had severe headaches and epistaxis and then lost consciousness, and his cerebral angiogram showed saccular aneurysms along the anterior cerebral circulation, which again evoke the retinal macroaneurysm. Another 14-year-old boy had a stroke. Unfortunately, in his angiogram showed significant paucity of the middle cerebral artery branches, which again resembles the arterial narrowing that we see in the retina, and another patient died from cerebral hemorrhage. And now involvement of other organs is seen. Splenic artery aneurysms in one patient, portal hypertension, and liver involvement, particularly cirrhosis, is also seen. So what is this IGFBP7? This is now known as angiomodelin. It is an angiocrine factor expressed in the CNS vasculature and in larger retinal arteries, but not in capillaries, and it affects vasculogenesis and angiogenesis. And patients with FRAM do not express the protein, and therefore this upregulates a pathway that is involved in the cardiac phenotype. How do we manage FRAM? Well, first of all, it starts with good recognition. We have to remember it. Now that you know the features, you have to remember it and anticipate the ophthalmic and the systemic consequences. And the ophthalmic management usually is laser to the macroaneurysms that are leaking. This is really effective, but you need to follow these patients and repeat it if necessary. Evacuate subretinal blood, do vitrectomy if there's an intense big vitreous hemorrhage, and drain exudative retinal detachment. And most importantly, monitor for leakage and bleeding. Confirm the diagnosis of genetic testing is needed, although the features can be very typical, but it's good for confirmation, and it also will enable you to carry on the other systemic management, which must be done in a timely and a crucial manner. A baseline echocardiography is a must-have, particularly looking for supravalvular pulmonary stenosis, which is very common, but also an abdominal ultrasound, preferably a polyangiogram or a brain MRA to look for intracranial complications. So in conclusion, retinal arterial macroaneurysm is a recognizable syndrome with characteristic combination of ocular and systemic life-threatening manifestations. It must be considered in the differential diagnosis of Coates or Irvan. A thorough cardiovascular evaluation is crucial. Conversely, and this is what we don't think much of, is a retinal exam and a possible angiomodelin mutation should be considered when you have a cardiac or systemic retinal arterial disease, and early recognition can greatly reduce the threat to vision and life. I would like to take a moment to acknowledge my colleagues, Dr. Hardeep Dinza and Dr. Ahmad Aboud, who during a moment of serendipity shared their patients. Now they were examining patients and they had no clue that those patients were related, but the same family. And through the collegial collaboration that we proud ourselves and having at the King Khalid Eye Specialist Hospital, they shared that information together, and they were able to recognize that this was actually running in the family. And this led to a full lot of work at with Dr. Lin Abu Safiya, working at the time with Dr. Fuzan Al-Karaya's lab to identify the gene, and later to the contribution of many of my colleagues, ophthalmologists and also internists, in further defining the phenotype of FRAM. And this has come lately in our latest publication that you can see here. And this has now would not have been possible without the patients at KKESH and the possibilities at the King Khalid Eye Specialist Hospital, which we consider our mother institution and for which we are so, so proud. Thank you very much for your attention.
Thank you very much, Dr. Sausan, for this excellent presentation. Now, will you introduce the next speaker? Or
definitely, yes. You can hear me, right? Yeah. Well, I would like to introduce Dr. Aung Tin, who is Executive Director of the Singapore Eye Research Institute at Singapore. In Singapore. He's a senior consultant in the glaucoma department and the deputy medical director for research at the Singapore National Eye Center in Singapore. He will talk to us today about the discovery of the SHED gene, how a family in the clinic can drive new genetic findings, genetic counselings, when and how. Dr. Ting?
Thank you very much. I'd like to say hello to all my friends in KKESH, particularly Dr. Abdul Aziz, as well as Deepak Edward in the glaucoma team. And of course, Khalid Abu Ameru, I heard, has just joined KKESH again as well. So this is actually a very old study I'm presenting, but it's to illustrate how a family in the clinic can drive new genetic findings. And I know that SHED is a very common disease, relatively common disease in Saudi Arabia. I have no disclosures. So I come from Singapore, and as you know, this is in Southeast Asia. And this is some pictures of Singapore for those who have not been. It's a very hot city on the equator, but probably not as hot as Saudi Arabia. And we have about 6 million people in a very small island. And unfortunately, for the last 2 months, this is how Singapore looks like. Instead of being very crowded, it's quite empty because we've had like a partial lockdown. And I usually fly a lot from the Changi airport, but look at how empty it is for the last 2 months. Even now, only about 10 flights a day probably flying from Singapore. And this is my hospital, the Singapore National Eye Center. It's very similar to KKESH, and probably about the same size, a little bit smaller. And we see about 350,000 patients a year, about 60% of Singapore's patient load. And this is the research institute, which is part of the SNEC, or SERI. So my background is I'm an ophthalmologist, and I did my training in Singapore. And I also did a PhD in molecular genetics at the University College London, in fact, the same time as Leen Abu Safir. And this is my boss during my PhD, Professor Shomi Bhattacharya. And I started a genetics group at SNEC in 2004. And currently I work as a glaucoma specialist with a research interest in glaucoma, as well as molecular genetics of eye diseases. So we're swapping now to the cornea, and as you know, there are different layers of the cornea, and I'm talking particularly about the endothelial layer and the endothelial dystrophies. Of course, this is not my specialty, but I'd like to tell you an interesting story of how we discovered the SHED gene. So SHED, as you know, is hereditary endothelial dystrophy, and it's characterized by corneal opacification with not much any other anterior segment abnormality, and there's a very thickened decimase membrane. It's of course a childhood disorder, but people usually, children usually have pretty good vision acuity until probably about teenage years when they go blind due to corneal opacification. And there's either autosomal dominant or recessive SHED. So we were interested in SHED2, which is a recessive SHED, and this is previous work had localized the genomic region to chromosome 20 between these two markers, about 3.5 megabytes of sequence. So the story actually started on a teaching trip to Yangon in Myanmar. So Yangon is a country in Southeast Asia. Myanmar is a country in Southeast Asia, and the SNEC often have trips there to teach ophthalmologists there. And a group of us actually identified a recessive family from Myanmar with this interesting corneal dystrophy. And here's a picture of Myanmar up in the upper left and Singapore. So we're about a 2.5-hour flight away. And of course, being not a cornea specialist, I didn't know what it was. Of course, we had to consult our cornea head, Professor Donald Tan, who identified it as SHED. And that was how the work started. So it was actually an interesting family. And this is a family which comes from a village near the border with Thailand. It's called the Karens. And this is the group of people who are who are very known in Myanmar for having a separatist war against the Burmese government. Anyway, so they have these Karen guerrillas and separatist movement. Nevertheless, so this was the Karen family that saw us in the Yangon Eye Hospital. And you can see here the inheritance pattern. This is a consanguinity, and with two cousins marrying. And there are 4 affected individuals in this family, all affected children. So, of course, interested in inherited diseases, I asked permission to examine and investigate this family further with our colleagues in Yangon, and we managed to obtain the bloods of this family. So this is how it started on a vision trip to Rangoon, Myanmar in 2005. And of course, when we came back from Myanmar, we actually kept the blood in the freezer for many months because we had inertia as usual. But one fine day, we decided to take a look at the family, and we then ran markers of chromosome 20, expecting it to be a CHED2. And sure enough, we found that this family did link to this chromosomal region. Now, at that time, the gene for CHED2 had not been discovered. And so we were interested to try to identify this gene. And you can see here the linkage areas. Now, this area is a very gene-rich region. And in those days, we didn't have next generation sequencing. We had to do Sanger sequencing. And basically, you had to start sequencing gene by gene, try to identify mutations in the particular family. And interestingly, one day, one of my colleagues, Iranga Vanna, she was reading a paper in IOVS, and she found that there's this gene called SLC4A11, which is very down-regulated in the cornea of Fuchs dystrophy, endothelial dystrophy patients. And of course, that piqued my interest because we know that Fuchs is also an endothelial dystrophy. And so we said, hey, it's interesting because that gene lies smack in the interval of our locus. And this is the gene that encodes sodium bicarbonate transporter, SLC transporter family. And that really made us scratch our head because we never knew anything about the role of bicarbonate or borate transporters in the eye. And we first looked at the endothelial expression, and true enough, the gene was very highly expressed in the corneal endothelium. And so we started sequencing the gene, and interestingly, we found a mutation on exon 17 of this gene, which segregated very well with all the affected individuals, and of course, not in the unaffected individuals. So we found a potential gene from Myanmar on CHED, and we needed to get more families to confirm our findings, and we contacted called friends from England and Leeds University, Chris Inglehan, who had, interestingly, 4 families in the UK of Pakistani descent of CHED. And we also contacted my friends in India at the Aravind Eye Institute in Madurai, and Dr. Sundaresan had 5 CHED pedigrees, all collected already in his freezer. As you know, Aravind is the largest eye hospital system in the world, and they see more than 1.7 million patients every year. So whenever you have any interesting eye condition, you can contact Aravind. I'm sure they have lots of every disease known in the world. And they have a huge number of patients, and they were very collaborative, and they were happy to explore these families together. And so we did start sequencing these families, 4 from the UK and the rest from India, in to sequence the CHED, this SLC411 gene to see whether it is truly involved in CHED2. And we're very lucky that we found mutations, 7 mutations in all families, showing that CHED2 was genetically homogeneous. And there were some common mutations, in fact, between some families. And you also look at the homology of the SLC411 gene, you can see that it's a very well-conserved region of the genome. And these mutations are particularly affected, looks like, the cell membrane. So altogether, we found all these mutations in various families, starting from Myanmar, and then of course the Pakistani and other Indian families. Subsequently, we were with our colleagues in India and the UK. Now, this gene is very expressed, as I said, in the corneal endothelium as well as epithelium. And one of the cornea buttons we managed to get with a mutation showed the SLC4A11 expression was even more downregulated in those affected with the mutation. And here you can see the normal and those people with the mutation. Now, the gene is also expressed in many different tissues of the body, and this is because it's a borate transporter. And what did it see next if this gene function is affected when you have the mutation? And we collaborated with our friends from the University of Alberta, Joe Casey and Patricia Morgan. Now, in those days, we didn't actually know them. We just contacted them by email and said, oh, we have this interesting family and this interesting findings. Can you help us do some of these functional work? And they were very nice. Usually, when you send such cold emails, you may not get much of a reply, but they were very interested to collaborate further. And they then did a series of experiments to see what happens to these genes, to these mutations, and what it does to the gene. And what they did was firstly, they found that the mutants did not process through the endoplasmic reticulum to the plasma membrane, and so they accumulated in the endoplasmic reticulum. And they showed that there was actually a failure of glycosylation, and this is the reason why they could not process this protein. And then they found that they proved it again that these mutants were defective in the movement, particularly to the cell surface, and so they failed to reach the cell surface, and that's why it could not express its function. And they were retained in the cytoplasmic locations, especially the endoplasmic reticulum. And so the disease is actually caused by functional loss of this gene. And this is the functional data to prove the loss of function in people with these mutations. So this is how it all started, from a family in Yangon, and how we discovered a new gene, SLC4A11, which is a sodium borate co-transporter. And then we showed that it was present in multiple families and it causes loss of function. Now, we don't know much about the role of borate still in the eye, and up to now, we still don't know how borate is involved, but we believe that it's involved in cell cycle regulation, and perhaps there's some deregulation of the MAPK pathway. And we don't know how exactly, in which stage of development this occurs, but we think it occurs during the growth and differentiation of neural crest cells during the formation of the endothelium. Now, we also know that SHED is characterized by thickening of the decimase membrane, and it shows that there's some abnormal pattern of endothelial synthesis and secretion. And we think that there's some dysfunction of this protein leads to a dysfunctional osmotic gradient. And gradually, with time, it gets loss of the barrier function and corneal edema and corneal opacification. So in summary, this is the work that we did more than 10 years ago in how we identified the SLC4A11 gene from multiple families with CHED2. And we were very lucky at that time to publish this paper in Nature Genetics. Subsequently, we also looked at the role of SLC4A11 in Fuchs endothelial dystrophy. As you know, this is another form of endothelial dystrophy, and it's pretty common, especially in Asia. Now, Fuchs is, of course, not so inherited as in most of the forms of Fuchs are late onset disease and usually affects people above the age of 40, leading to progressive endothelial dysfunction and finally corneal edema and blindness. And of course, as you know, there are different stages of Fuchs, and this shows you how it progresses from the early stages of corneal guttata all the way to epithelial edema and bullae. And these are the characteristics of corneal guttata. Now, there are two main forms of Fuchs, as I told you earlier, the early onset of familial Fuchs and the late onset of sporadic Fuchs. And so we wanted to know whether the CHED gene was also implicated in late onset Fuchs, because we know that in the eye, different mutations in the same gene can cause varying phenotypes. And so we sequenced this SLC411 gene in patients with Fuchs endothelial dystrophy from Singapore, Hong Kong, and India. And we found several mutations of these SLC411 gene in Fuchs endothelial dystrophy. And here's showing you some of the affected mutations, and also just showed you that it affects the post-translational modification of the SLC411 gene. So we also found that the mutant forms, again, were retained in the cytoplasm, just like the work we did on CHED. So approximately, we believe that approximately about 5% of late onset Fuchs endothelial dystrophy may be attributed to SLC4A11 mutations. And since then, we know that Fuchs is very complex in terms of genetics. There's an early onset dominant Fuchs, which is mainly caused by mutations in COL8A2. And among the late onset Fuchs, there have been genetic variants in TCF4, SLC411, as well as other genes implicated. And of course, TCF4 is of course a gene of interest now because of the potential possibility of gene therapy with TCF4 repeats. So in summary, I would like to share with you today a story of how one family in the clinic started it all on a trip to Myanmar when we saw an interesting family with a corneal dystrophy, which I did not recognize. But of course, thanks to my colleagues, my cornea colleagues, Professor Donald Tan, we knew what it was, and subsequently we started the long adventure and journey to identify the gene and what it does. And of course, I'd like to stress to you the importance of multidisciplinary, multi-center collaborations. We cannot work in isolation. I need to acknowledge colleagues, particularly our geneticists. We also need to colleague the statisticians, the scientists, and the pathologists involved in all this work. And I strongly believe that research is a team sport. I'd like to acknowledge particularly Eranga Vithana, who led most of the studies in Singapore, as well as my collaborators in Canada, in Leeds, the UK, in India, in Yangon, as well as the collaborators for the study of the Fuchs dystrophy from Hong Kong and from India, and support from the National Medical Research Council of Singapore. So this really shows you a multinational, international type of collaborations from different parts of the world. Thank you for your attention.
Dr. Schatz, you're muted. Oh, I see.
Okay, we have two questions now. The first question on CHED. So please choose your answer. And the second question is on linkage analysis. Is the method to study the genetics of particular diseases. And here are some of the options. So shall we go to the answer? Next. Response? Okay, so yes, it's frequently inherited autosomal recessive. And the second one is correct. Now, linkage is not so useful to study AMD, and I will discuss this in my subsequent talk on different complex diseases compared to inherited diseases. Thank you for your attention.
Thank you, Prof. Ong Tin, for this very informative and interesting lecture. Next speaker is Dr. Amani Al-Bakri from King Khaled Eye Specialist Hospital. Dr. Bakri, she did fellowship in ocular genetics at the Wills Eye Hospital in the USA. And she was the chief of the pediatric division in KKESH until very recently. You're most welcome, Dr. Bakri. We're looking forward to hearing your talk.
Thank you, Dr. Patrick. Is my voice clear? Hello? Hello?
It is clear.
Yeah, and
do
you see my screen? Is it clear?
No, we don't see your screen.
You don't see it? Okay. So let me just see what's the problem. Yeah. What about now?
Now we see it. Now we see it.
Okay. So welcome everyone, and I would like to welcome you to KKESH Ocular Genetic Conference. It's a great pleasure to have everyone from all over the world. I would like to thank our CEO, Dr. Abdulaziz Al-Rajhi, for his usual support and direct supervision. I would like to thank the chair of the conference, Dr. Samar Suwainam, for her dedicated work to make everything looks great. I would like to thank our speakers for accepting our invitation, and I would like to thank the scientific committee members for their guidance to make everything as beautiful as it today. So the reason I picked up genetic counseling is because I feel that as clinicians, we're more busy in the clinic looking at the clinical aspect of the patient. And I believe that patient, doesn't matter to the patient how long do you stay on their history, on their test, as long as you answer all the questions they have in mind. So if Majid, you can put the poll questions. I just put general questions and see what's the audience reply. I'm sure that not all centers have genetic counselors, but we can see what do you say. So do you know what is the true role of a genetic counselor in the genetic clinic? And the other question is, if you had a genetic test for a patient and the result was difficult to interpret and the patient came for counseling, what's the next step? Are you going to explain to the patient, even if there is no enough evidence to prove the pathogenicity? Or you're going to call someone who knows, like a geneticist or a friend that you trust, and counsel the patient based on the phone call? Or you will refer the patient to a specialized geneticist to do the counseling? So we can give like 15 seconds and then see the answers. Okay. Can we see the answers, Majid? Okay. So, okay, most people know, and they will refer patient to a genetic counselor. Okay, so when we talk about genetic counseling, let me just move. So the definition of genetic counseling is the process of helping people to understand and adapt the medical, psychological, and familial implications of genetic contribution to the disease. Now, this process integrates three parts. First one is interpretation of the family and medical history to assess the chance of the disease occurrence or recurrence. Second part is education of the patient itself about the inheritance, testing, management, prevention, resources, and research. And the third one is counseling to promote informed choices and adaptation to the risk or the condition. Now, the practice of advising people about the inherited traits began in the 20th century. Shortly after that, we had the term genetics. The term genetic counseling as a term was first introduced in 1947, and the first published book was in 1955 about counseling in medical genetics. The first master degree was in 1969 in the United States, and the first National Society of Genetic Counselors was founded in 1979. Now, genetic counselors, we're lucky we have one genetic counselor in our hospital, and hopefully soon our second colleague will graduate. They are professionals who have specialized education in genetics and counseling. They provide personalized help to the patient they may need to make decisions about their genetic health. In 2018, there was nearly around 7,000 genetic counselors in around 28 countries. In the States, there is about 39 accredited programs, and in Canada, there are 5 accredited programs. And I know in Saudi Arabia, we have 3, one in Al Faisal University, another one in King Abdulaziz University, and the third one is in Al Qura University, which is a 2-year master. Now, there was a nice paper published in the European Journal of Human Genetics where there was a Saudi contribution. And when you look at the population of our community, among 32 million, we have only 20 genetic counselors. And that's a very small number in comparison to the true need we need in our community. So why do we need to do genetic testing? Why do we care? Simply because if the patient knows what is the genetic eye disease they're having, we can give them answers to more specific questions. Understanding the natural history and prognosis, knowing the systemic care patient needs in some syndromes, knowing the inheritance and recurrence risk estimates, the blood test for pre-symptomatic diagnosis of relatives, the screening protocol for some cases like glaucoma, the prenatal testing options, and the last thing and the most important is research categories. Now, when we look at counseling, it has three main elements: the pedigree, the pre-testing session, and the post-testing session. The pedigree is usually, ideally, it's obtained by the ocular genetic counselor, but in some centers where we don't have, it's usually either the ophthalmologist who's going to order the genetic testing or the ocular geneticist. It can be either by phone contact or can be face-to-face. It's supposed to be that this first contact informative and positive experience to relieve the patient fears. The main aim of the pedigree, other than knowing the history of the patient itself, is knowing the medical and social issues surrounded for the patient and the extended family, and knowing who's of support to our patient. These are just diagrams showing you the different types of inheritance and showing you the symbols that you should know before taking a pedigree for a genetic patient. Now, pre-testing session is usually where we see the patient before ordering the test. It's supposed that the pedigree already taken by the ocular genetic counselor. We examine the patient and have the clinical presentation. We look at the genetic inheritance of the condition by looking at the pedigree. We look at the different available procedure and testing. Some patients will have some questions about the reproductive options, about the therapy, and sometimes we have to refer patient to different specialties in case we suspect a syndromic entity. The post-testing session is after when we have the test result. And this usually helps the families to cope with their emotional, psychological, medical, social, and economic consequences. It's not easy to tell the patient that you have a disease that has no cure and just leave the patient like that. Some patients, and we do see them in the clinic, they have denial, they have anxiety. Sometimes we have guilt, especially mothers. Sometimes we have blame, where the husband or the wife blame the other opposite family. We have also, we provide patient information about the community resources, the support groups, and if the genetic test is positive, sometimes we consider testing other additional relatives. Now, I just want to show you that sometimes the genetic tests are complicated when you have, like, for example, a microarray that has multiple genes involved, or it can be a single gene mutation, but you still have to look for this variation pathogenicity and look at the different databases. We tend to use the online Mendelian inheritance in man, and if you type in the gene here, you will find that there are different databases that you can study the different variation, different mutation, and any reported studies before. Also, it's the importance of the genetic counselor or the ocular geneticist or the ophthalmologist who's ordering the test to look for the patient if there is any ongoing clinical trial. And nowadays, patients are more educated and they come in the clinic and ask you, is there any ongoing research in any other country? It's the responsibility of you as an ophthalmologist or an ocular geneticist or a genetic counselor to look at the trials and see if your patient fit any clinical trial, and you can contact the group who's conducting the trial. Now, the most difficult step, I believe personally, in the clinic is when you deliver the diagnosis to the family. Although we feel discomfort when we give them the diagnosis, especially that there is no treatment, but patients can feel that we are unfeeling or uncaring for their problem. And believe me, nobody wants to be in this bad situation, but if you deliver it in an empathic way and give them time to absorb the bad news, it will leave a better impact on them, and the communication between you as a physician and the patient will be easier forward, and they will trust you. As I said, we should, when we give the patient the diagnosis, we have to give the patient privacy if they would like to sit alone as a family. Sometimes they don't want to talk immediately. We can schedule them for another visit if they don't want to talk on that session. And we can make them feel that what you're going through is normal. You're not alone. Always advisable to connect families with each other. Sometimes when they know there are some other families going through what they're going through, they feel kind of normal or have a better feeling. Now, common questions, and these are discussed in details in the book that I will mention in the reference later on. a lot of questions that we get in the clinic, and sometimes it's difficult to answer all of them, is the family or the patient itself asking, am I going blind? What's normal vision? What does my child see? Will my child need will need to go to special school? What are the job opportunities? Will he drive in future? Will I need a white cane? Does anyone else have what I have? And that's the importance of the support groups. And what is the strategies for adjusting to vision loss, especially when I see a teenager patient getting worried, what's the future like? Now, I always believe that we should not tell the patient that we don't have anything to offer. There is always a rehabilitative and counseling services. There's low vision services. There's contact information for resources of low vision, foundation for blind and support groups, and also proper genetic counseling. Now, I believe there's a need for more ocular genetic centers specialized to offer genetic counseling, genetic testing, and other supportive services needed by this group of ocular patients. Ocular genetic services and ocular genetic counseling require financial support, all of us know, from governments, health institutions, and insurance companies. And for those who are interested to know more about ocular genetic, most of my the reference that I used is Dr. Ilyas Trablsi book. He has a chapter about genetic counseling. And for those who want an easygoing book in the clinic, we have the Will's Eye Manual. I would like to conclude with this slide, that every child has the right to live a normal life. And until a proven therapy can be offered to each patient, all patients should be given hope. Thank you.
Thank you very, very much, Dr. Amani. Wonderful practical talk. I would like to now again welcome Dr. Arif Khan, Professor of Ophthalmology at the Cleveland Clinic Lerner College of Medicine and consultant ophthalmologist in pediatric ophthalmology and genetics at the Cleveland Clinic in Abu Dhabi, where he will talk to us today about ERG, the full field ERG. When do we need it? A very, very important talk for the entire audience, whether they do retinal fellows and general ophthalmologists and residents, whether they're specializing in retina or not. Go ahead, please, Dr. Khan.
Thanks, Dr. Sausen. Can you hear me and see the screen?
I do hear you, and we can see your screen. Yes.
Okay, terrific. I'm really thrilled actually to give this particular talk, because I would say that, I don't think it's an exaggeration to say full field electrophysiology is probably one of the most misunderstood tests in ophthalmology. And I find over and over again that many colleagues just don't have a good understanding of what it is. And some people even think that it's obsolete. Why do we need it? Now that we're in the 21st century, we have multimodal imaging, we have genetic testing. Why do we need full field ERG? Well, I would actually argue that we need full field ERG even more now with the genetic testing and with the multimodal imaging to understand what's going on. And I hope it will be my goal from this presentation is to make you understand when do we need full field ERG. It's not my goal to make you understand how to do an ERG. It's not my goal to make you understand how to read an ERG. I want you to understand when do we need an ERG, and this is something that all ophthalmologists should understand no matter what they're practicing. Maybe it's a good idea to start with the questions. If we have the questions, do we have the poll questions? No poll questions? Then I'll just go ahead. I had submitted some. Oh, there we go.
You do have them.
Okay, let's just get an idea of what people think about these situations. A child with non-traumatic optic nerve pallor, one, needs a full field ERG to demonstrate optic neuropathy. B, needs a full field ERG to rule out retinal dystrophy. C, does not need an ERG because there's optic nerve pallor, so it's an optic neuropathy. Or D, does not need an ERG because it will not provide useful additional information. That's the first question. It's a common scenario we see in the clinic. Here's another question. A patient has a non-recordable full field ERG. It can be concluded that which of the following is decreased in this patient? 1, central retinal thickness. A, central retinal thickness. B, visual acuity. C, night vision. or D, retinal ganglion cell layer thickness. So it's okay, you know, I think we all should just answer as we think, just to get an understanding of what our conception is. And I'll give a few minutes for that, a few seconds for that. And we'll see the answers, then we'll go through the talk and maybe we'll ask those two questions again. Could we see the answers just for the polling? Okay. All right. Good, so let's go through the talk. Okay. No financial disclosures. So the full field ERG is a measure of the electrical activity of the retina under standard conditions, standard testing conditions. We have some standard stimuli under some standard conditions, and we record the response, the global response of the retina to that. That is the ERG. It's a pan-retinal measurement. We're measuring the electricity of the entire retina. It's a measure of global retinal function. So if you have a central macular scar, and that's the only abnormality, the full field ERG will be normal because that is just a small contribution to the retina. It's the entire retina that's being looked at when we do a full field ERG, and small changes in sectors of the retina are not going to be affected. It's a measure of global retinal function or dysfunction. Of course, when we send in the standard light stimuli, it has to go through the anterior segment. So if there's any type of video opacity, that is going to affect the amount of light that gets to the retina. That's going to decrease the standard stimulus. That's going to affect the ERG recording. We need to put some electrodes on the eye to measure the electrical circuit. These are DTL electrodes. They're very commonly used. And when we do this, when we do the standard full field ERG, we're doing a dissection of the retina on a global basis. We're dissecting inner from outer retina based on our readings, and we're dissecting rods from cones, again on a global scale. This is the full field ERG. Now I like this graph that shows rod and cone densities across the horizontal meridian in the retina. Center 0 is the fovea, and that's where cones are densest. We have the highest density of cones in the fovea, and there are no rods in the fovea. But an important point that people tend to confuse is that although cones are most dense in the retina, in the fovea, most of the cones are out of the fovea. In the fovea, there are about 200,000 cones, but in the retina, outside the fovea, there are about 6 million cones. So the cones are mostly outside the retina. If you just have a maculopathy, full field ERG will be normal because, if you have an abnormality of just the macula, the global cone function is not going to be abnormal because most of the cones are outside of the fovea. About 20 degrees from the fovea is the highest density of rods, and the retina really is a rod-rich structure. There are about 20 million rods in the retina, as opposed to 6 million cones, only 200,000 cones in the fovea. And here's a nice cartoon that shows all of those stringy things are rods, and the retina is a sea of rods, and those little greenish things here are some cones scattered here and there every now and then in the retina. Of course, this is extrafoveal. We have great multimodal techniques now to look at the retina. I could not imagine looking at a patient with a retinal disease without looking at OCT or autofluorescence. These are great techniques. Didn't have them when I was in residency, but they are not a substitute for the ERG, because while these multimodal techniques show a structure, the only technique that shows us function is the full field ERG, and that's the role of the full field ERG. The standard full field ERG measures function. As I've said, it's a gross response of certain standardized stimuli to the retina under certain protocols, and then we see the retina dissected electronically, rods from cones, inner from outer retina. It's important to highlight what the standard full field ERG does not give us. The standard full field ERG does not measure ganglion cell function, so it's not going to tell you about optic nerve function. It does not indicate foveal function, so no information regarding the visual acuity, because the fovea is a small part of the retina And the full field ERG is a global retinal measurement. So you can have a patient with a non-recordable ERG and 20/20 vision. You can have a patient with a hand motion vision and a normal full field ERG. It doesn't tell you anything about visual acuity. It doesn't add information if there are no photoreceptors. If you have a patient who has obvious retinal wipeout, who has very advanced retinal dystrophy, and it's clear on the exam, there's no point in getting an ERG because if there's no structure, there's not going to be any function. And finally, it does not substitute for a clinical exam. I say this all the time, a good ophthalmologist, an average ophthalmologist, is much better than excellent electrophysiology, because electrophysiology by itself is meaningless unless you have a good clinical exam, and you have to have a specific question which you want answered by the clinical exam. That's where full field ERG comes in. I am not going to go through tracings in this talk. I will just refer to them every now and then. But again, we're dissecting rods from cones and inner from outer retina. Now let's go to the indications. And the first indication for full field ERG is when you see a patient with pigmentary or fibrotic changes in the retina, and you have a question if there's global retinal dysfunction. When you see changes in the retina and you want to know if it's part of a pan-retinal problem, the only way to know that is by doing a full field ERG. So here's a 50-year-old woman who was coming in for a blepharoplasty. She had an eye exam before blepharoplasty, and she has this pigmentary changes. She's 20/20. She has no symptoms. You can see these pigmentary changes. They're present in both eyes. Is this a sign of retinal dysfunction? There's only one way to know. Full field ERG. And when she has a full field ERG, she has rod cone dysfunction. She had a mild form of retinitis pigmentosa. Here's a 4-year-old boy who comes in with accommodative esotropia. We're doing a full exam and you see these funny fibrotic lesions on the retina. What is going on? Is this part of some kind of retinal dystrophy, dysfunction? Again, to tease that out, we need to do a full field ERG. And again, I'm not going to go through ERGs in detail, but because Dr. Selson is watching, I will show this one. We have here the 4 different waveforms standard. This patient has no rod response, has a dull, decreased, mixed, combined response, rod and cone. The cone response is similar. The flicker is down, particularly the A wave. This is one of the pathognomonic ERGs. This ERG is a pathognomonic signature for the enhanced S-cone syndrome. Now, most of the time when we do an ERG, we don't get a pathognomonic ERG, but there are a few situations where the ERG actually gives us a genetic diagnosis. And in this patient, we just made a genetic diagnosis without doing any genetic testing. This child has a pathognomonic ERG for the enhanced S-cone Goldman-Favre syndrome. These patients have also classic clinical features. Sometimes they just have some fibrosis, which can be confusing, but when you do the ERG, the diagnosis becomes clear. The next indication for full field ERG that I'd like to share with you is maculopathy. I see many times that a patient has a bullseye maculopathy and they get the label macular dystrophy. You cannot label a patient with a maculopathy, macular dystrophy, unless you've done an ERG, because when you have a maculopathy, it's either isolated to the macula or it's part of a pan-retinal dysfunction. And the only way to tease that out is by doing a full field ERG. As a matter of fact, for at least most of the patients that I see, when I see a patient with a maculopathy, usually it's part of a pan-retinal dysfunction. Usually it's not an isolated maculopathy. Only way to know is by doing a full field ERG. So here's a 12-year-old boy with decreasing vision. The right eye is shown, the left eye is similar. He's got a maculopathy. This is something that needs an ERG to understand what's going on. And when we do an ERG on this patient, he's got a cone rod dysfunction. It's a pan-retinal dysfunction. It's actually ABCA4 retinopathy with cone rod dystrophy. Only way to diagnose that he has cone rod dysfunction is by doing an ERG. Here's another 12-year-old boy with decreasing vision. He also has a maculopathy. What do we have to do? We have to do an ERG to understand what's going on. So when we do the ERG, this patient has a little bit of a different pattern. He's got no rod response. He's got poor cone response, but paradoxically, he has a large combined response. This is another one of those pathognomonic ERGs. This ERG is pathognomonic for a condition known as cone rod dystrophy with supernormal rod response. And it's exquisitely specific for biallelic mutations in KCNB2. Once again, we've made a genetic diagnosis without doing any genetic testing. This condition is found commonly in the region. When we looked at our patients in Abu Dhabi, children with retinal dystrophies, it was the second most common cause of retinal dystrophy. The clinical picture varies, but the ERG is pathognomonic. Again, the diagnosis is by ERG. Here's a 6-year-old boy with decreased vision in the left eye for 2 years. He's 20/60, and he has long-standing poor vision in the right eye. His long-standing poor vision is because he had an unoperated retinal detachment in the eye and cataract. It was said to be after trauma. When we look at his left eye, he's got some sort of cystic changes in the macula. He's got some pigmentary changes in the rest of the retina. Once again, maculopathy, we need to do an ERG. Actually, his maculopathy is a schisis in the center of the retina. And when we do the ERG on him, we find he has poor rod response, and he has this electronegative waveform where the A wave is much bigger than it should be, and the B, no, actually the A wave is normal, and the B wave is much smaller than it should be. Cone dysfunction as well. This is a signature for X-linked retinoschisis. Now, very often we can diagnose X-linked retinoschisis clinically, and we don't need an ERG to make that diagnosis. But sometimes they come with primarily macular findings, or they come with subtle findings, and the diagnosis is not that clear, as it often is. And in that situation, when we do the ERG and we see that electronegative waveform, the diagnosis becomes very clear. Moving on to our next indication for full field ERG, non-traumatic optic nerve pallor, particularly in children. Why? Because when you have optic nerve pallor, it often is from optic neuropathy, but it can be from retinal, it can be secondary to retinal degeneration. You might wonder, you might say, well, wouldn't it be obvious from the retina? Well, no, you can have retinal degeneration and the retina looks normal. It can look normal on multimodal imaging, but it can be not functioning properly and cause a secondary optic nerve pallor. The only way to know whether it is dysfunctional or not is the full field ERG. So here's an 8-year-old boy with poor vision since he was 2 years old. He's 2400, has a prior diagnosis of optic neuropathy. He's had an MRI that was normal. His OCT is normal, his autofluorescence is normal, he's myopic. Well, we have to do a full field ERG to know what's going on. It's not complete just to say that the retina is normal by multimodal imaging. We have to do an ERG. And when we do an ERG on this patient, he's got poor rod function, he's got poor code function, and he actually also has an electronegative ERG. This is a signature that's very specific for a particular gene mutation. This is specific for CABP4 mutation. It's not completely specific, but it's very suggestive. This is a congenital cone dysfunction we see in the region. Sometimes it's categorized as a form of congenital stationary night blindness, but I don't like that because these patients don't have night blindness. I see Dr. Rolla is going to be speaking about congenital stationary night blindness later, and I'll be very interested to see what she says about this disorder. But often the retina looks normal, and often they have optic nerve pallor. The only way you're going to diagnose that the patient has a retinal dystrophy is by doing a full field ERG. Here's a 9-year-old girl. She had decreased vision for the last year in school. She also has diabetes, and she has bilateral optic nerve pallor. In her, when we do the ERG, it's normal. This girl does have an optic neuropathy, and when we do an OCT on her, she has inner retinal loss. We need to do an ERG to make sure that we're not dealing with the retinal dysfunction associated with the optic nerve pallor. Now, my fourth indication is probably the biggest indication for full field ERG, and that's when we have unexplained poor vision or nystagmus, particularly in children, or poor night vision. I see many children with nystagmus where the retina looks normal, going for MRIs, and it always upsets me because the vast majority of these patients have a retinal dysfunction that would be revealed by ERG testing. Poor night vision, also, this is something that is not well understood. You'd be surprised. People who have poor night vision and normal multimodal imaging often are just left at that and told that everything is fine, but some of them have retinal dystrophies, even though the multimodal imaging is normal. You have to take the complaint of poor night vision seriously. So when we have a child who comes in with poor vision and everything looks normal and they have nystagmus and there's no optic nerve pallor, this most often is a retinal dysfunction, and we can tease it out by doing a full field ERG. It's a classic indication for full field ERG. There are some classic diagnoses that you can make depending on the pattern of the ERG. I'm not going to go through them because of issue of time, but the child with who's apparently blind with the normal fundus afferens needs an ERG, and the pattern can tease out different retinal dysfunctions. Now here's a 6-year-old girl referred for strabismus. She has esotropia myopia, and her mother complains she has really poor night vision. She was seen by a retinal specialist and told that she doesn't have any retinal problems. She wasn't referred to me for a retinal issue. She was actually referred to me for strabismus surgery. And she has myopia, she has esotropia, she has nystagmus, as we often see in strabismus. And the retina, it does look normal, and the multimodal imaging is normal. But never ignore the mother. She says she can't see at night. This patient needs an ERG to investigate that complaint. And so her fundus looks normal other than myopia. Her multimodal imaging is all normal. And when we do the ERG, there's no rod function. She has an electronegative waveform. She has normal cone function. She has classic congenital stationary night blindness. Now I'll tell you, I can't tell you how many patients with congenital stationary night blindness are out there who were not diagnosed because the multimodal imaging was normal. I'm telling you now, if you have a patient who is complaining of poor night vision, even if the multimodal imaging is normal, that patient needs an ERG. That's how we diagnose congenital stationary night blindness. I didn't list CABP4 here as one of the genes, although when you look in the textbooks, they'll list CABP4, the condition I mentioned before, because I don't like considering that congenital stationary night blindness, although it's often grouped with that group of disorders. My final indication is an indication I just want to mention for completeness. I'm not going to give any examples. It's when you want to quantify panretinal function or panretinal dysfunction after an intervention or over time. For example, if a patient had gene therapy or a patient is on a toxic medication or was taken off a toxic medication, one way to follow these patients is doing by full field ERG. Although I don't find that a good indication because, as I've said several times, full field ERG is a measure of panretinal dysfunction and it is not going to pick up small changes. So there are better electrophysiology techniques to follow patients after gene therapy or patients who are on toxic medications. But I just mentioned full field ERG for completeness. So to summarize, I've gone through what I consider indications for full field ERG. As ophthalmologists, we need to know these indications if we're going to practice ophthalmology. The one thing I want to stress is that the ophthalmology exam is much more powerful than electrophysiology, and electrophysiology needs to be ordered to answer a specific question after an ophthalmologist has made an initial impression. So thanks for your attention, and I'm looking forward to the rest of the meeting. But should we put up those questions again? Do we have those questions?
Most of the questions have been answered live, but of course.
Oh, no, then we don't have to.
I'm just thinking that because of the sake of time, we may not want to go unless there are some burning questions, but we've seen that you've answered a lot of questions live. And there was one question regarding the use of anti-VEGF In FRAM, which I also answered that it is not indicated because the pathway of the gene is different than the VEGF pathway, and so laser is more effective. But of course, if there are a few questions that have not been posed, please let us know. We will give it like 2 minutes, and then we will break for coffee and prayer and then resume. If there are more questions, we're happy to answer them. You can raise your hand or type them.
People can ask in the chat also. There have been people asking questions in the chat. I've answered a few. I've typed them.
Yes.
So that's another way.
Yes, they're all exhibited. So if people have questions, they have been exhibited and answered. I do not see questions that have not been answered. And a lot of people are thanking the audience, the speakers actually, for the very nice presentations, and I join my voice as well.
Second session will be again an interactive, therefore you're encouraged to participate in the poll questions and to submit your questions in the Q&A box at any time. These questions will be entertained at the end of this session. Dear speakers, panelists, a kind reminder, mute yourself if you are not presenting, and there will be a reminder sent to you when your presentation is about to finish. I want to just start this session by introducing my co-chair, Dr. Aman al-Bakri. And first presentation will be given by Dr. Rola Ba'abad, a consultant in King Khaled Eye Specialist Hospital, Vitreoretinal Division. She's going to present the congenital stationary night blindness. Dr. Rola.
Hello again, and thank you for having me over. I'm just going to share my screen. And okay, all right. So I would like to thank Dr. Arif Khan for making my probably life easier during this second talk, and it's something that is close to my heart. I spent years literally actually working with patients with congenital stationary night blindness, doing psychophysical testing for my PhD studies. So this is a condition that I feel much like home talking about. So I'm presenting basically an argument. I mean, this is my disclosure. All the clinical data are courtesy of the ERG department at Moorfields and the Department of Genetics at Moorfields, London. So basically, this is a simple cartoon that the origin of the visual signal starts from the photoreceptors, the rods and cones, as just Dr. Arif Khan showed. The signal travels from the photoreceptors to the on and off bipolar cells, and the on and off bipolar cells relay the signals to the ganglion cells. There is always modulation of the signal, so it's actually fine-tuned at different levels by the horizontal cells and the amacrine cells, although we don't know exactly how these cells electrophysiologically contribute to the full field ERG, but probably psychophysically some of these cells become relevant when it comes to color vision and so on. So it's quite interesting to see how the retina actually works. And if you start at the phototransduction cascade, I'm not gonna delve into the details of the cascade. Suffice it to say that basically quite a lot of these steps, actually anything that goes wrong, I mean, the reason that we have that many steps is basically that we need this to amplify the signal. So a properly dark adapted rod would be able to signal even to the perception of the person, a healthy person, the absorption of a single photon under ideal situations. So you can imagine how much this signal is fine-tuned, and actually it needs quite a lot of steps, but this comes at the price of actually there is no redundancy in the system. So if anything goes wrong, actually the cellular function and eventually the visual function will be affected. So back again to the first synapse, which is basically, this is like an upside down retina, and this is the synaptic terminal of the photoreceptor. Suffice it to say that in the condition called complete CSMB, you have actually the signal starting in the on bipolar cell and going through different steps, and mutations in several genes along a single pathway can present electrophysiologically more or less similar. So it gives you quite a lot of understanding. Once you understand what the phototransduction and the transmission of the signal, at least at the level of the bipolar cells, you can easily look at an ERG and say, probably there is something at this particular level that is causing the problem. Always like there will be always like errors and mistakes, but at least when you look at an ERG, you can start to think about which genes probably you might need to screen for. And this is basically, if you look at the rod light response, it generates the dark adapted dim flash response, which is practically generated by the rods, but actually the cell that is showing the response here is the on bipolar cell. And then when you increase the flash intensity still under dark adaptation, you have the phototransduction now in the rods showing up, and also the transmission of the signal is happening not only in the rods and the dark adapted cones, and it's transmitted through the on and off bipolar cells now. The reason that you have the off bipolar cells is that the cones have stepped in once you increase the flash intensity, but then if the eye is light adapted, then you have the full monte of the cells working. Now you have adapted the rods so they don't respond that much to your stimulus, but then you can now isolate the cone responses, and then in the flicker ERG you can see basically the response. 80% of it is actually the contribution of the on and off bipolar cells driven by the light adapted cones, which contribute to the response by about 20%. Again, if you use a single flash, you will have the light adapted cones and off bipolar cells contributing to the A wave, and then the B wave is actually the response of the combined response of the on and off bipolar cells. Now, why I'm confusing you with ons and offs and so on is because basically this is how you can approach the understanding of night blindness. And when you tell a patient, actually, you do have night blindness, and then they say, no, basically, I have some problem in bright light, then you have to believe them. So we're going to just carry on, and as hopefully it will become clearer as we carry on. So I completely side with Dr. Arif Khan that I don't like the word complete and incomplete CSMB. And this is a classification that was advocated for by Professor Yuzo Miyake in Japan. And it was fantastic at the time because actually they did have clear signals on ERG even before the genes were known for these disorders. So at the top is what we call the complete CSMB, in the middle is the incomplete CSMB. And one striking feature is that in the middle row here in the incomplete CSMB, not only that you have the electronegative signal, but then you can see that the cone responses are actually quite significantly affected. And we'll come to this soon enough. But basically, this is a synaptic disorder. The photoreceptor phototransduction is actually normal, at least as far as we can tell from the electrophysiology and the animal models. So now we move on, and basically, because we can just go back to this, and basically you have the modulation of the neurotransmitter from the photoreceptor, the glutamate, is actually helping in the modulation or the fine-tuning of the photoresponse that is eventually transmitted to the bipolar cells. So if the signal that comes from here is not sent to the bipolar cells with high fidelity, then you would expect these cells, even if they are working fine, because it's just like if you give noise to these cells, they wouldn't be able to work out a signal, and eventually the responses are not going to be normal. And this is actually basically encoded by 2 or even 3 genes that modulate the function of the calcium channel in the photoreceptor synaptic terminal. So we go back there, and CIBP4 is another gene because it comes from the same pathway. The condition has been labeled still under the umbrella of incomplete CSMB. Despite that, if you compare these, I mean, these are not, you know, there is quite a bit of variability, but you can see, I hope you agree with me, this is the right eye and left eye of the same person with a homozygous deletion of exon 6 in this gene. And you can see clearly that the electronegative ERG is remarkable, but the cone responses are almost, you know, severely attenuated, and those patients are classically extremely photophobic, and they do have very poor color vision. Some of them even behave functionally as if they are achromats. So when you have a patient like this and you tell them that you have incomplete CSMB, it wouldn't make sense to them at all. And it shouldn't make sense to you because yes, it has been lumped under the same category, but it doesn't functionally behave the same way. And adding to complexity, I just showed in the earlier lecture the deletion in CAC-NA2-D4, which is encodes actually for a modulatory subunit of this calcium channel at the photoreceptor. And then the phenotype is completely different. For a starter, even those patients that we have seen so far, they don't have electronegative ERG to start with. And the cone function is also reduced, and it has an unusual waveform. On top of that, also patients do have problems in bright light. They do have problems with color vision, and their night vision is actually better than their daytime vision. Again, you sit with a patient, you tell them you have a form of incomplete CSMB, it wouldn't make sense to them. So I'm just not going to take longer than this, but you know, in the literature, usually all of these conditions are lumped under the big umbrella of CSMB, and it comes in several flavors and in several forms of inheritance. And you know, the more we know about the genotypes of those patients, the more we learn about them mechanistically, and then there will be always surprises. So Dr. Arif Khan showed in one of his slides SLC24A1 as a cause for what's called Riggs type ERG, which is basically absent rod responses, and the retina behaves as if there are only cones there, and the cones are technically work completely normal almost in those patients. But here's the surprise. If you are a retina aficionado and in this OCT scan, you will notice that the ellipsoid zone here is actually interrupted just right there. And this
can we conclude in 1 minute, please?
Yes, absolutely. So what I'm trying to say is that this gene has been actually recently associated with autosomal recessive retinitis pigmentosa. So we are changing completely the game. Another disorder that we thought of as a stationary night blindness disorder, Oguchi disease, have been shown in patients, if they are old enough, actually, that it causes autosomal recessive retinitis pigmentosa. So in conclusion, I'm basically advocating that now that we have mechanistic understanding of various genetic disorders, I suggest, or I promote actually revising the CSMB into several categories that signify our understanding of the synaptic disorders, disorders of the phototransduction cascade, and disorders of the visual cycle. Thank you very much for your attention.
Thank you, Dr. We'll take the questions at the end of the session. So we're gonna welcome our, you wanna go through the full questions?
Sure. So the first question is regarding CSMB, which statement is true? A, patients are always aware of difficulty under dim light as far as they can recall. B, fundus examination shows abnormalities in only Oguchi disease and fundus albipunctatus. C, genetic testing is of no clinical use as these are all stationary disorders. D, ERG and molecular testing should be prioritized in infants with congenital nystagmus. I think Dr. Khan's lecture has given quite a lot of clues to the answers. The next question is, in stationary night blindness, which statement is false? A, patients will always have trouble driving at night. B, adult onset symptoms should prompt investigation by fundus imaging, ERG, and serum vitamin A level. C, absence of rod function on ERG means that the patient has retinitis pigmentosa. So I will give you a few 10 seconds to answer these questions. Okay, so the first question, about 73% of the audience answered correctly that D is the true statement. ERG and molecular testing should be prioritized in infants for reasons that Dr. Khan has brilliantly covered. The other thing is that why it's not true that patients experience difficulty under dim light is because, as I mentioned, quite a lot of those patients actually have problems with the cone function, and therefore it's actually under bright light that they struggle most. So just for the interest of time, I'm just going to skip to the next question. In station eye blindness, which statement is false? And the correct answer is A and C. The reason for that, I mean, these are two false statements. The reason for that is that patients who do have trouble at night, not necessarily is because of night vision problems. Actually, driving at night using, flash light or floodlights and the street light is actually basically you're driving under mesopic conditions where the rods and cones are both working together. So probably patients with trouble at night might not have, trouble with night vision. Probably driving at night wouldn't be their most concerning problem. And then the second thing is that absence of rod function on ERG means that patient has RP for reasons that I just mentioned earlier. Some of these conditions, they do switch off the rod signal, but that doesn't mean that it's going to progress to retinitis pigmentosa. Thank you very much.
Thank you, Dr. Rola. Thank you so much. So we're going to move to our second talk, and our speaker, Dr. Arif Khan. He's going to be talking about spherophakia and ectopia lentis, phenotype, genotype correlations, and management implications. Thank you, Dr. Khan.
Thank you. Can you hear me?
Yes, we do.
Okay. Great. So now moving to the front of the eye. There's no such thing anymore as idiopathic spherophakia or ectopia lentis. Over the last 10, 15 years, we really have uncovered the genetics of spherophakia and ectopia lentis. And now we pretty much know more than a dozen causes. And there are phenotype, genotype correlations to this. And of course, the management is affected when we know the underlying pathology and what we should and shouldn't do. In the time allocated to me for this talk, I'll go through a few of the more common causes for spherophakia and ectopia lentis that we see in the region. I have no financial disclosures. Of course, we know the lens is suspended by zonules in the anterior chamber. If there's sectorial weakness of the zonules, the lens moves the lens subluxates in its plane. If there's complete 360-degree weakness of zonules, the anterior posterior diameter of the lens tends to increase. We get spherophakia. And if all of the zonules are fragile or fragmented, the lens might luxate into the posterior chamber or anterior chamber. That's the terminology that we use. And I'm going to start now with the major cause of spherophakia and ectopia lentis. It's actually the major cause of ectopia lentis. It's the big one that we've all heard of. It's FBN1 mutation, and as we know, also associated with Marfan syndrome. Now, fibrillin, which is encoded by FBN1, is a component of the zonules. So it's not surprising that when we have fibrillin mutation, we have ectopia lentis. The zonules in fibrillin mutation get stretched. They tend not to break. They tend to stretch and be weak, and there tend to be some intact zonules in other places of the eye. It's, why do these patients, though, have Marfan syndrome? Why do they get the overgrowth? It's interesting. It's because FBN1, fibrillin-1, also acts as an inhibitor of transforming growth factor beta. And when there's fibrillin mutation, transforming growth factor beta is disinhibited and is overexpressed. And it's that overexpression that causes the bony overgrowth, the cardiovascular abnormalities, et cetera, that we associate with Marfan syndrome. Now, I'm not going to go through the features of Marfan syndrome. I think we would all recognize anybody who had Marfan syndrome, obvious Marfan syndrome. But there's one thing I want to point out, one feature I'd like to point out to us as an audience of ophthalmologists. And take a look at this patient. Take a look at this patient with ectopia lentis and his face. Does he look happy? Does he look sad? Well, he looks sad, but he's not sad. He has a myotonic face. It's the face we see in fibrillin mutation. In the literature, sometimes it's called lugubrious, which is just a fancy word that means sad. And take a look at this patient, this child with ectopia lentis, and this child with ectopia lentis, and this child with ectopia lentis, and this one. They're not from the same family, they're not related, but they all have ectopia lentis fibrillin mutation. And there's a recognizable face that we see. So even if we're not looking at the entire body, just take a step back when you have a patient with ectopia lentis and take a look at the face. Do they have that myotonic face that suggests fibrillin mutation? These are two extremely important points that I really want to highlight. Young children with ectopia lentis can have fibrillin mutation without obvious non-ocular features. They might get them later or they might never get them. However, if they have fibrillin mutation, they are still at the risk for progressive aortic root dilatation and sudden cardiac death. So we must prove that every child that we see with ectopia lentis, even adults, that they don't have fibrillin mutation, or refer to someone else, because the implications of having that are very important. Second, fibrillin mutation is the predominantly cause of apparently isolated ectopia lentis in this region. We see a lot of recessive disease. We see recessive ADMTS10 mutations causing ectopia lentis, recessive LEPRL1 mutations, but still the #1 cause for ectopia lentis in this region is still dominant fibrillin mutation. We must rule that out in every patient we see with ectopia lentis or refer to someone who can do that for us. What are other ocular features suspicious for fibrillin mutation? These patients have large flat corneas. They typically have a homogeneous iris, myotic pupil, and of course they have a myopic retina with a risk for retinal detachment. I want to share with you this case. He's a 30-year-old with lens subluxation. He's aphakic when I saw him, and pediatric retinal dystrophy. Here he is. He was referred to me. I'm wondering, is this a new lens subluxation retinal dystrophy syndrome? But wait a minute, let's look at his face. Does it look familiar? This patient has the face of fibrillin mutation, and sure enough, he has fibrillin mutation. What about the retinal dystrophy? Well, he has fibrillin mutation, and he has another mutation in a different gene that's causing him retinal dystrophy. He has two different diseases. Again, fibrillin mutation is the most common cause for lens subluxation in the region. Now, how do we manage fibrillin-related ectopia lentis? This is a talk in of itself. I'm going to summarize how I manage these patients, particularly children, with one picture. And here it is. Most of these patients can be refracted. There are patients who need surgery for sure, but in my experience, the vast majority can be refracted. And sometimes you refract through the aphakic portion and give them the glasses. Sometimes you refract through the phakic portion and give them myopic glasses. It just depends. And these children are much better off if you can postpone surgery as much as possible. Again, there are exceptions where you have to do surgery as a child. And here's a father and a son, both with fibrillin mutation. The father is refracted through his myopic portion of the lens, and the son is refracted through his aphakic portion, although he took off his aphakic glasses for the picture. When surgery is indicated, I like to take out the lens. I don't like to play around with CTR rings in children who have a genetic defect of the zonules, because all of the zonules are weak. That's something that's for discussion. So fibrillin is the big cause. Now let's go on to some rarer recessive causes. And the first one of these is CBS-related homocystinuria. This is a condition we all have to be aware of. It's an inborn error of metabolism, And these patients have a metabolic defect that causes dislocation of the lenses, mental retardation, osteoporosis, and thromboembolism. They can present to us with ectopia lentis. Often the lens is in the anterior chamber because the zonules tend to fragment and children have very well-formed vitreous. It's very important to pick these patients up because early dietary modification prevents mental retardation. What an impact you can have in a child's life diagnosing these patients early rather than late. There are many different types of homocystinuria depending on where the defect is in the metabolic pathway. But as ophthalmologists, we really only have to be worried about one, that's CBS enzyme deficiency, because those are the children who will come to us undiagnosed. They'll come to us with the lens problem, and we are in the position where we can pick up these patients early. Again, in CBS-related homocystinuria, unlike in fibrillin mutation, the zonules tend to break. And in children, the lens tends to come into the anterior chamber. Patients with homocystinuria have been said to have a Marfanoid habitus. As a matter of fact, Marfan syndrome and homocystinuria were both thought to be the same condition originally, but with biochemical analysis, careful phenotyping, and genotyping, we know they're very distinct conditions. Again, homocystinuria is a metabolic condition that we should diagnose early so that dietary modification is initiated as soon as possible. There is another cause of ectopia lentis in this pathway here, sulfite oxidase deficiency, number 8 over here. I used to never talk about it because when I would talk about ectopia lentis, I would say that these children are in the ICU. They're not going to come to your office. So it's not as essential to know about. But recently I saw a patient come to the office, so I just have to mention it. Sulfide oxidase deficiency. These patients are really sick. They're going to come to you with the diagnosis already, but most of them are not going to come to you. Most of them are in the ICU as very young children, and they don't survive. When I used to say that to residents and fellows, when a child comes in with the lens in the anterior chamber, it's almost 100% homocystinuria. But I can't say that anymore because there's one other diagnosis where this happens, and I'll summarize with this other diagnosis. In this other diagnosis, the zonules also fragment, and the lens also tends to come in the anterior chamber, but at a much younger age than homocystinuria. In homocystinuria, it's typically 6 or 7. In this other diagnosis, it's typically in infancy. And the other thing about this other condition is that they always have a very large cornea, and they have spherophakia before the lens prolapses into the anterior chamber, so they have a lenticular myopia. The condition I'm talking about is LTBB2-related megalocornea. LTBB2 mutations cause fragmentation of the zonules, and so these children get spherophakia and a tendency of the lens to come into the anterior chamber. These patients don't have this. LTBB2 interacts with fibrillin, but these children do not have the features of Marfan syndrome. They have this unique ocular phenotype of megalocornea, zonular weakness, spherophakia, and a tendency for the lens to come into the anterior chamber. These children sometimes get confused as primary congenital glaucoma because they have big corneas and they can have pupillary block and high pressure. Very important to recognize them because if you do angle surgery in these children, it's a disaster. The treatment for this condition, as is the treatment for homocystinuria-related ectopia lentis, is to remove the lens. Doing peripheral iridotomies and things like that is not going to get you anywhere because that lens is going to continue to move forward. I'll just share with you, this is a child who was thought to have congenital glaucoma. He actually had this condition, LTBB2-related megalocornea with zonular weakness. He had angle surgeries for glaucoma, and he ended up with bilateral retinal detachments and bilateral lens subluxation in the posterior chamber. He never had an angle problem. The problem is the zonular weakness and the megalocornea. Here's another child. He came with the lens in the anterior chamber. This lens is subluxated. Look at the size of these corneas. Megalocornea with zonular weakness, LTBB2 mutation, lens has to come out. Here's another child. This child is only 2 years old, came in with this presentation. 15 years ago, I would have been considering homocystinuria, although I would have think it's strange that the child is only 2. Now I know that this is LTBB2 mutation. It has to be at this young age, especially with the size of that cornea. His younger brother, also the same thing. He almost had surgery from glaucoma by another surgeon, but we were able to intercept that because he had big corneas and every now and then his pressure was high from pupillary block. Good thing he didn't have angle surgery. The management of anterior lens luxation, whether it's from LTBP2 mutation or CBS-related mutation, is removing the lens. Doing peripheral iridectomies for these patients is useless because that lens is going to keep coming forward no matter how many peripheral iridectomies you do. I think I'll stop there because of time. I've gone through 3 scenarios of spherophakia ectopia lentis that we see in the region. Every child that comes in with ectopia lentis, we have to write down why we think it is not fibrillin mutation and why it is not homocystinuria, because these patients need to be recognized early because of the systemic implications. If we don't feel comfortable doing that, we must refer to someone else who does. For those of us who treat congenital glaucoma, beware of this LTBP2 related megalocornea with zonular weakness. These children get confused as congenital glaucoma, but the problem is a primary megalocornea and zonular weakness with the lens moving forward. Thank you very much. I think that's what I have time for.
It was a great presentation, Dr. Khan. So I would like to welcome the next speaker. It's Professor Gavin Arno. He's working currently as an principal investigator in Foresight Early Career at the UCL London, and he's the senior research scientist at the Great Ormond Street Hospital for Children, North Thames Genomic Medicine Center in London. He's going to present a very interesting topic, and the title of his presentation, as shown here, he's going to discuss the 100,000 Genomic Project results, and we're all excited to hear his presentation. Professor Arno.
Hi, thank you very much for the invitation to speak to you today. Can you all see my screen okay?
Yes,
okay,
it's very
perfect.
clear.
So yeah, thanks for the introduction then. I have no financial disclosures. Just a little bit of introduction then. I don't need to go into any detail as to what inherited retinal dystrophy is, obviously. But just to recognize that molecular diagnosis is still challenging, and we think there are a number of reasons for this. So the broad spectrum of highly variable diseases, and we've been hearing about some of those today. The high genetic and allelic heterogeneity that we see in inherited retinal dystrophies, covering all inheritance patterns. And so in the UK then, the current state of retinal dystrophy genetic screening, we can still do some single gene tests by direct Sanger sequencing. Really, this is reserved for monogenic and disease hotspots. Some of these are listed here. Broadly, genetic testing nowadays in the UK is done by targeted gene panels, and a couple of examples here. One performed at the Manchester Centre for Genetic Medicine, the retinal dystrophy panel, which is a targeted gene panel done by probes. And then at Great Ormond Street Hospital, they have a similar panel, although this one is done slightly differently. This is a post-sequencing virtual panel done on a clinical exome test. So we're moving towards unbiased screening now, and what we mean by that is covering all of the genes in the genome, or indeed all of the genome. And one project that's focused on doing this is the UK 100,000 Genomes Project. And so the problem that we have these days is the missing heritability. Then we're able to solve somewhere in the region of 50 to 60% of our retinal dystrophy patients at Moorfields Eye Hospital. Other centres have variable diagnostic rates. And why are we unable to solve some of these cases? Well, we think there are still novel genes, although each of these novel genes probably account for an ever diminishing proportion of cases. Hypomorphic alleles, so milder alleles associated with more severe diseases. We may be seeing these more and more, and I'll talk about that in a little bit more detail later. New genotype phenotype associations, non-exonic variants, structural variants, and then some non-Mendelian causes as well. And so whole genome sequencing, therefore, allows us, with its unbiased analysis technique, allows us to preserve the dosage of the genome. So this works in a different way to whole exome sequencing or gene panel targeted sequencing, in that there is no enrichment step in the technology. So dosage of the genome is preserved, which allows us to characterize copy number variants, gains and losses of chromosomes and so on much more effectively. It also means that we can read through GC-rich regions, which is difficult by PCR-based technologies, which struggle to read through GC-rich regions. We cover all of the intronic and control regions of genes, and this is particularly relevant for important genes in retinal dystrophy. We can cover all of the introns, the promoter region, transcription factor binding sites, regulatory regions, and so on. And then we generate entire coverage of the genome, which gives us these chimeric and split read data. So the nature of the technology, paired end reads sequencing, enables us to examine not just the sequence, but how these paired end reads are aligned to the genome. Are they the right distance apart from each other? Are they oriented in the right direction? And so on. And this enables us to characterize structural variants that are only possible to be characterized by this. So things like inversions, chromosomal translocations, and complex rearrangements. But there are still challenges. There are things that we can't sequence using this technology. So there are intractable repetitive regions in the genome. So things like RPGR or 15, which is highly repetitive and is longer than the paired end reads that whole genome sequencing gives us. So that means it's very hard to align the reads to that sequence. And duplicated genes or pseudogenes, where two genes have a very similar sequence, causes huge problems for whole genome sequencing to be able to align the reads. So the data is another challenge. This technology generates a huge amount of data, huge numbers of variants, somewhere in the region of about 4 million single nucleotide variants per individual, which makes filtering and prioritization of the rare pathogenic mutations very difficult. And storing and handling this data is a huge challenge as well. And so in the UK, to overcome some of these difficulties and to integrate whole genome sequencing into the National Health Service, this project was designed way back in 2012. The discussion started for this project, and it's the 100,000 Genomes Project, and it's split into two arms: cancer and rare disease. And we're interested in the rare disease arm, where families, and particularly trios, affected children and their unaffected parents, were recruited for whole genome sequencing, covering non-monogenic rare diseases. And recruitment was split between 13 genomic medicine centres across England and the UK. And a huge part of this project is the research part, whereby the data is available for researchers across the UK and worldwide. And so far, so this slide's a little bit out of date, but so far there are about between 2,600 and 3,000 researchers accessing this data across 46 research domains. And our domain is the hearing and sight domain, the hearing and sight GSIP. And so ophthalmology then within this project. So overall there are about 73,000 rare disease participants, covering about 34,000 families. So nearly 3,000 of those are ophthalmology probands. Nearly 2,500 have a posterior segment abnormality, so broadly speaking, a retinal dystrophy, and about 1,500 of those were recruited from Moorfields Eye Hospital. So this covers about 8% of the entire rare disease project. And so far through the clinical pipeline, and I'll talk about that more in a second, we've solved about 60% of our Moorfields cases. And so that clinical pipeline then involves a virtual gene panel test. So this is essentially the same as a gene panel test, just done on whole genome sequencing data rather than targeting. And this panel covers 313 genes, and this is curated by expert users. So the app is called Panel App, and you can log in to Genomics England Panel App and look at the panels, comment on genes, add insight, and help improve the system. And so the way that this works is it filters the variants based on them being protein altering, affecting a gene in the panel, and having a minor allele frequency of less than 1% in control data sets. And using this, the variants are tiered into either being damaging or known pathogenic. So these are the high priority variants, or tier 1 variants, likely damaging or known missense variants, which are tier 2 variants, and then everything else is classified as being tier 3, which are essentially variants of uncertain significance or benign variants. And so, as I said, this solved about 60% of our patients. And so we're interested in the unsolved cases as part of our research at Moorfields and the Institute of Ophthalmology. And we're performing various analyses on these cases. So we're using targeted non-coding variant interrogation as one arm of this research. And this is to look for candidate intronic variants in genes that we already know cause a retinal dystrophy. And we're using a small number of families and patients to do this, those with characteristic phenotypes or presentations or family histories for particular genes or a few particular genes. For example, we can look at all of the intronic variants in ABCA4, where the patient clinically has Stargardt disease and may have one coding mutation. We'll be looking for the second non-coding allele in that family. Or monoallelic, so again, monoallelic, so patients who carry pathogenic or likely pathogenic variants in the recessive gene. So we'll be looking at the second hit in those cases. So we're also performing structural variant analysis using the Illumina designed algorithms MANTA and Canvas. And the way that these work, so MANTA works on looking at the split read data, so the reads that don't align properly with their partner in the whole genome, or don't map to the genome properly. These are picked up by MANTA, and Canvas is an algorithm that looks at read depth abnormalities across the genome. So we use these two algorithms to characterize firstly the coding regions of known retinal dystrophy genes, and then expanding out of that into the non-coding regions and into novel genes as well, looking for candidate structural variants that are causing disease. And we're looking at the cohort on a larger scale, so looking at the entire cohort of unsolved retinal dystrophy cases, or breaking that down into phenotypic groups, and then looking for recurrent, novel, ultra-rare variants or genes that are occurring within those patients, and comparing that to the control data set, so the wider data set and the parents, the unaffected parents of non-retina cases, for example. And also looking at the consanguineous family cohort and looking for candidate homozygous variants within those. We can also use linkage data, and we can look for linkage within this cohort. Everyone in the cohort had a SNP array test done at the same time, so we can look for regions of homozygosity across those. We can look for linkage using our old data that we've generated prior to this study, and we still have some large families who are unsolved, who are recruited for whole genome sequencing. So combining those two data sets, we can look for linkage for dominant disease and so on. So moving on to some findings then from this study. So I said in my title that we identify novel genes and unusual causes and non-coding variants. So I'm just going to go through a few examples of those. So this was a novel gene that was identified in part through the 100,000 Genomes Project in conjunction with some historic linkage data, candidate gene sequencing, targeted analysis. And this is the single-stranded binding protein 1, which causes a dominant optic atrophy. And this is just an overview of the clinical features and the families that were recruited to our study. Now, I'm not going to go into any detail about this study, but we found through this project 3 different missense mutations. This is a dominant disease, so heterozygous missense mutations in this gene, clustering into a region that's important in the tetramer assembly and DNA binding in this protein. And if you want to read more detail about that, this is the paper that came out last year in Annals of Neurology. So I'm going to move on to some other unusual forms of disease now. So mild alleles in severe disease genes. So Dr. Khan touched on a few of these earlier on today, and so did Rola. Now, finding missense alleles in syndromic disease genes in either isolated retinopathy or an attenuated phenotype, attenuated syndromic phenotype, is an emerging phenomenon that we've noticed over the last few years, particularly. And I think one reason that we find these now is that as we're moving on to larger gene panels and whole exome sequencing and whole genome sequencing, we're able to detect these off-panel missense variants and also have the confidence in causality that we're provided by excluding all of the known causes of disease in these cases. So a few examples of ones that we've seen over the last few years: IFT140, AHI1, CLN3, MFSD8. These are all genes that cause a severe syndromic disease, but we're finding specific missense alleles occurring in our retinopathy cases. So I'm going to go through one example of this in a little bit more detail. So this is a 31-year-old male who was diagnosed at the age of 17 at Moorfields Eye Hospital with a mild RP, sensory neural hearing loss, and some mild cognitive impairment. So at the time, looking back at the letters from the time, he was diagnosed with an atypical Usher syndrome. These are clinical imaging. And so we found in this individual, we found by whole exome sequencing 2 missense variants in the gene SGSH. And these are both previously reported variants. And what does the gene do? Well, it causes a mucopolysaccharidosis type 3A or Sanfilippo syndrome. And it's usually associated with a childhood onset severe central nervous system degenerative disorder and death in the second to third decade of life. But these 2 variants have been reported before in cases, and in particular the serine 298 proline is reported as a slowly progressing attenuated phenotype associated variant. So that, we think, solves that case, and it leads to adjustment in clinical care and some difficult discussions with the families, obviously. And then, so moving on to previously undetectable mutations. So these are all non-coding variants and structural variants that are found in our cohort. And they represent a list of variants that are found in greater than 15% of our unsolved cases. And all of these ones have either been validated already in our laboratory or they're currently under investigation in our laboratory. And so I'm going to talk about one particular example from this list. You'll see choroideremia, the CHM gene is found. We found candidate intronic mutations. We found candidate upstream 5' UTR mutations, and we've also found candidate deletions in this gene. So choroideremia is, as we know, an X-linked recessive chorioretinal atrophy. Hemizygous loss of function mutations, typically loss of function mutations in this gene, are found, and this is associated with a loss of the REP1 protein function. And so it's important that we're able to diagnose these affected males, since gene-based treatments are already underway, trials are already underway. And at Moorfields, we have 4 affected males who underwent whole genome sequencing in this study. They'd all had prior negative gene testing for the CHM gene. These are the first 3 probands here, all with fairly typical choroideremia features. And our fourth patient was actually was diagnosed very young because his mother had carrier signs and he had a family history. So he's quite a young boy with relatively early disease. Now, we don't need to be unbiased when we're analysing a patient with choroideremia. There's only one gene that really causes this, so we can focus specifically on that gene in our whole genome sequencing data. So it's a very small 186 kilobases of the 3 billion base pair genome that we need to be concerned with here. So we do this, we look for the rare variants. In fact, these variants aren't even necessarily that rare. The variants of less than 1% in the general population here. And we find that in patient 1, patient 2, and patient 3, there are only one candidate variant each of which are never seen before in any control individuals. And what I hope you can see here is that patient 1 and patient 2 actually have the same rare variant. Patient 3 has an upstream variant, position -98 from the A of the ATG start codon, and patient 1 and patient 2 share this deep intronic single nucleotide change. Now, we can analyze these variants in different ways. So what do we, when we see a novel deep intronic single nucleotide variant, one mechanism of disease that springs to mind is cryptic splicing. So we can ask various algorithms to predict what this variant would do to potential splice size. And what we can see from this data here, hopefully, is that we have our wild type sequence analyzed on one side, our mutant sequence analyzed on the other side, and then below the nearby predictions for the partner splice size. So our wild type acceptors for a chunk of this intron, about 2 kb chunk of this intron are shown here. And you can see there are some fairly strong predicted acceptor sites in this piece of sequence. And there's an additional one that's predicted caused by this single nucleotide change. So this very strong splice site prediction here. And we can see just downstream of that, there already exists a good, strong donor site. So these are the two things we need to make a cryptic exon. So this is our hypothesis that this single nucleotide change deep in an intron introduces a novel and cryptic acceptor site, which can be partnered with this downstream donor site to make a cryptic exon. Now we're lucky that CHM is a gene that is expressed across all tissues. So we can go back to our patients, take a fresh blood sample, extract RNA, and test this hypothesis. So we can do an RT-PCR spanning exons 3 to 5 of the CHM gene and see what transcripts we get from that. And we did this with both of our patients, and the mother, the heterozygous obligate carrier of one of those patients, and a control specimen here. And we can see that the wild type band is represented nicely in the control. The mother had a partial transcript, partial wild type transcript, and an extra band, about 200 base pairs, a bit higher than that. And each of our patients only had this alternate band in their agarose gel electrophoresis. And then when we sequence that band, we find that indeed our prediction was correct. There's a cryptic 224 base pair exon included into that transcript, which leads to a frame shift. Here's position 105, where the serine is altered to an arginine, and then 10 codons downstream, there's a stop codon. So the effect of this deep intronic variant is actually a frame shift of the CHM transcript. Now, patient 3 didn't have a deep intronic variant. He had an upstream variant, so we need to think about different mechanisms of disease in this case. So we looked for potential regulatory region effects, so promoter region and transcription factor, binding site alterations, and enhancer regions for this. And we collaborated with a group in Alberta on this who had found a different nucleotide change at the same position And they did these beautiful experiments where they cloned the region into a luciferase reporter plasmid and showed that each of these two variants, so their variant, which was minus 98C to A, and our variant, which was minus 98C to T, were both enough to completely abolish luciferase expression from this regulatory region. And so this confirms that, that this variant is likely to abolish the CHM gene transcription in vivo as well. And so patient 4 then, so we looked at rare candidate single nucleotide variants in exactly the same way, and we didn't find a single candidate variant in this patient. So we were a little bit disheartened by that. We hope to find something similar in this case. So we looked for structural variants as well that were found in this region. And we found there was a single candidate structural variant, which was identified in intron 12 of the gene. It encompasses about 5.8 kb of entirely intronic sequence within that gene. And so this is a snapshot of the IGV browser, and you can see here, hopefully some of you will be used to looking at this kind of thing, but you can see here the chromosome at the top, which is chromosome X, obviously, and we're looking at a 9.755 base pair, kilobase pair fragment of chromosome X in the window below. And this is in this is exon 13 of the choroideremia gene. Choroideremia is on the reverse strand of exon of the X chromosome. So we're looking at the gene backwards here. We can see the coverage of the gene with this grey plot here, and the individual read pairs below it are represented. And so what we can see here is that there are a bunch of reads from this whole exome sequencing experiment which are flagged as red. They're given a red tag, which means essentially this means that there's a gap between them that's too big. The software doesn't like these reads because they're too far apart in the genome. And we can see a whole bunch of other messy flagged reads. We can sort these reads out by their tag, and we can see indeed that there's a group of reads that are flagged because they're red, with a complete lack of coverage of this region of the chromosome. So this signifies that there's a deletion within this single copy of the X chromosome, hemizygous male. So we've also got these kind of turquoisey blue reads at the side, and these are flagged because they are oriented in the wrong way. So reads should be facing each other. They should be pointing inwards and facing each other, like the primers on a PCR amplicon. But these reads are actually facing in the same direction. And what that tells us is that at one end of this deletion, which is all entirely intronic, remember, one end of this deletion, there's a 219 base pair inversion. We can characterize this from the whole genome sequencing reads because we're able to look at these cut ends of the reads that don't align properly. So we know that we've got a 5.8 kilobase deletion with a 219 base pair inversion at one end of it. That's all in the intron, so we don't really know what that's doing to the coding sequence. But we can have a guess at what's happening here, and again we look at cryptic splicing effects. So we look within this novel piece of sequence, this inverted piece of sequence, and we can see that there are donor and acceptor splice sites, which are, you know, canonical almost in their strength, and these are brought together in this intron by this inversion to form this 45 base pair pseudo exon that we can predict from this analysis. And we don't have any RNA to analyze this as yet. This is something that was about to be done before coronavirus came to the UK. So this is ongoing work, and this is something that we hope to be able to prove in the near future. And so in summary then, so whole genome sequencing enables us to characterize the entire variant landscape across the genome. So we're able to cover about 95% of the genome with short read sequencing. We're able to perform these large-scale whole genome sequencing studies, and in retinal dystrophy cases, these are a rich resource for discovery. But what we really need to be able to do to capitalize on this is combine the genome sequencing data with deep phenotyping. That's the critical part of this, is that we need to work with our clinical colleagues and analyze the genome data along with the clinical data together to really be able to detect and to discover new things. We think that non-coding variants and structural variants account for a significant proportion of the missing heritability in retinal dystrophies. And the spectrum of these non-coding variants may be wide, perhaps not as vast as the spectrum of coding variants, but I think we'll detect many different types of mutations in patients moving forward. And we think that whole genome sequencing should be incorporated into clinical genetic testing pipelines for ophthalmic disease and broader Mendelian disease going forward. And I thank you for your attention today.
Thank you, Prof. Arno.
Is there any more questions? Yeah.
So the questions, so yeah, this is getting away from ophthalmology slightly for the questions here. I'm a basic scientist. So paired end read whole genome sequencing enables improved elucidation of which mutation type compared to gene panels or whole exome sequencing. And the second question was, which of the following is not a mechanism of non-coding variant gene disruption? Can we see the answers? Do we have a countdown?
Yeah, we have almost 60 seconds from the beginning. Okay, we're excited to see.
Okay, so paired end read whole genome sequencing enables improved elucidation. So the answer that I have is D. So a partial inversion of PRPF31 would be the only type of variant here that would be better seen by whole genome sequencing. So coding single nucleotide variant in ABCA4 is covered by gene panel tests. So this would not really be improved by whole genome sequencing. A variant in the opsin array, so the opsin array is gene duplication. So this is something that whole genome sequencing struggles completely to decipher. So because there are several copies of essentially the same gene, the short 150 base pair reads can't really be aligned properly with accuracy in the opsin array. So whole genome sequencing doesn't really help us for blue cone monochromacy patients. A frameshift deletion in USH2A is easily detectable by gene panels and exome sequencing, but a partial gene inversion of PRPF31 is something that exome sequencing would struggle with because it only covers certain parts of the gene, and likewise gene panels. But whole genome sequencing gives you the breakpoints of structural variants, enabling you to characterize them with accuracy to the nucleotide. And then the second question, which of the following is not a mechanism of non-coding gene disruption? So amino acid substitution is the answer there. So that's the only answer that's coding within a gene. All of the others are non-coding. So canonical splice site disruption. So splice sites are found just outside of the exon, so they're non-coding. Cryptic splice activation, we've talked about deep intronic cryptic splice activation and pseudo-exon formation. And transcription factors bind upstream of the gene. So again, those are non-coding. So we didn't do quite as well, I'm afraid, today. Thank you, though.
Right, you're welcome.
I will present our next speaker, Prof. Khalid Abu Amro. He's a professor of molecular genetics at University of Illinois, Chicago, Department of Ophthalmology and Visual Science in the States. He has a quite lengthy CV with a scientific career of 23 years and over, and he has more than 250 publications. Today, he's going to be talking to us about ophthalmic genetics at KKESH, the future ahead. You can go ahead. Thank you, Dr. Khalid.
Can you see the presentation?
Yes, we can see the presentation, but can you enlarge?
Okay.
Make it.
Okay. F5. Okay.
Yeah, slideshow.
I'm pressing F5, but it's not responding. Here you go.
Yeah, great. Thank you.
Hi, my name is Khalid Amro. I'm talking to you today from the beautiful state of Maryland in the United States. The weather today is very nice, 70 degrees Fahrenheit outside with slight humidity. I'm actually the CEO and the director of a company called Geneticom USA, which is my own business. I design softwares in personalized medicine and artificial intelligence for small hospitals. I'm also the director of operations at Stallion Tech, which is basically a family business for computers and servers. We design servers for government agencies. And I'm a visiting associate professor at University of Illinois in Chicago, Department of Ophthalmology, College of Medicine. Whatever I'm going to present today, actually, I have no financial disclosure, nothing to disclose. And basically, whatever I'm going to present today, it will be my personal vision of what the ophthalmic genetic operation should be at King Khalid Eye Specialist Hospital. And of course, the admin of the KKESH can, of course, accept, modify, reject, and so on. So this is just my personal view. Okay. So basically, the idea is to actually, the major thing when you run an ophthalmic genetic operation is to know what institute you are dealing with. Okay, so if you are, for example, at an educational institute like a university, the type of research and the type of work you do, it will be different from the type of work you do at a hospital like KKESH. Whereas, for example, if you are doing the research at a university, you might concentrate on basic science research. But if you are doing research at a hospital like KKESH, it might be more applied research. And I believe that this is the type of research we should be doing in terms of the ophthalmic genetic at KKESH, applied research, which can be translated to the patient care. There is no point in spending millions on research which have no value for the patients. It will look really odd, especially if you are a hospital caring for patients. Of course, this will allow, if you take that into consideration, it allows your operation to be sustainable for a longer period of time, and it will be a solid operation. Okay, the most important thing out of the operation, I believe that we should build a DNA and a tissue bank, okay? And that samples coming for diagnostics or research should end up in the tissue and the DNA bank. And that will be combined with a database where people later on can utilize the database and the biological material available at the tissue and the DNA bank for future research. So these are the type of samples I believe we should, from the blood samples, we can get the DNA, the RNA, the plasma, biological samples, aqueous, vitreous, or various types of tissues. All these should be actually stored in the tissue bank and documented. All the information related will be documented in a tight database where even the genetic testing will be there if it's available, and the information and the material will be very valuable for future research. I also believe that the genetic counseling is a very important factor in the process of dealing with genetic disorders leading to ophthalmic complications. And I believe that the genetic counseling should not end at the patient concerned or his immediate family, but it should be also, we should reach out to the extended family, trying to do genetic testing for them and counseling in order to benefit the patient communities. I also believe that certain programs like IVF, pre-implantation genetic diagnosis, should be activated. It's not necessarily it's done in our hospital, but certainly we should make contacts with institutes or health facility where basically these things can be carried out, collaborate with them, provide them with the genetic results. I mean, IVF BGD is a very important factor and process in preventing the disease happening from future generation and stopping the disease and having healthy children. It also helps in cases like, for example, retinoblastoma. Imagine for a disease like retinoblastoma, which is an autosomal dominant disorders, if you carry out IVF pre-implantation genetic diagnosis, you will be able to actually eradicate the disease within one generation. Not preventing it, but eradicating it. So that is, you see, the process, I believe it should be a patient-oriented, and we should involve in projects and which can be easily translated to the patient care. Now, the types of genetic testing hopefully we will have is single gene disorders by Sanger sequencing, and for monogenic diseases, for big genes. Nowadays, the exome sequencing cost is actually cheaper than before, and it can be done either locally or outsourced like we do now. It's outsourced. For complex diseases, less than 150 genes panel testing, we are planning to get the MySeq, and basically we designed the panel which includes so far 170 genes, and the genes involve various diseases like inherited retinal disorders, corneal dystrophies, strabismus, retinoblastoma, and so on. So I believe that the design of the panel should be based on literature, should be based on what you previously detected. So when we design the panel, we design it in such a way to take into consideration previous testing which has been done and literature is available and so on. There is no point in creating a chip, for example, for just inherited retinal diseases, where you can accommodate 220 genes currently known for inherited retinal diseases, but only 17 has been implicated in Saudi patients. Any patients who come, who is negative, he can go for exome, okay? But the idea is that the panel we design, or the KKESH panel for testing for eye diseases, should at least cover 50 to 60% of the tests which comes to you. The other percentages can be covered by, for single gene, can be covered by Sanger sequencing, and for things which are panel negative, we can go for exome sequencing. I'm not too much fond of the whole genome sequencing, especially for diagnostics. I mean, we can have a debate about this for hours, but I'm not really fond of whole genome sequencing, especially for diagnostics in particular. Of course, for known reasons, it's very difficult to predict what effect they have on the gene. And sometimes if you don't have enough individuals, you will not be able to segregate it with the phenotype. It's very, very complicated issues. And I don't think that is the focus of diagnostics for this type of work. Rare diseases, exome. As I said, exome, is becoming cheaper. There are some labs in the United States now perform exome sequencing for less than $500. And for a trio, they do it for something in the range of $700. We debated this, myself and Dr. Deepak, before about do we really need to bring exome to KKESH, but we found that the cost is huge. To get the Illumina HiSeq, we need something like 5 million Saudi riyals, and then in terms of the reagents and so on. So maybe it's easier to actually outsource it. So I'm a type of guy who will say outsource it. You will be able to pay much less, you will be able to maintain it, and you will get a good quality results. So I also believe in RACGH, RACGH for detection of deletions, duplications, and inversions, and all types of chromosomal abnormalities, which can be involved in, I mean, deletions has been reported for inherited retinal diseases, unsolved cases of inherited retinal diseases. Hi, is somebody saying something? Sorry, I'm hearing.
Can you conclude, please, in 1 minute?
Sorry, hello?
Can you please conclude in 1 minute?
Okay.
Can you hear us?
Yes, I can hear you.
Yeah. So can you conclude your presentation and move to the questions in 1 minute, please? Yes. Thank you.
All right. Okay. So the ophthalmic genetic diseases we are going to cover, hopefully most common diseases we see at KKESH. I believe also in registries, we should have, I believe we have an inherited retinal diseases registry, or that's at least the information I got from Dr. Deepak. And I believe we should have other, national registry for other diseases like corneal dystrophies, glaucomas, optic neuropathies, and so on. Of course, diseases caused by mitochondrial mutations, hopefully we will cover that. And ophthalmic diseases, as I said, caused by copy number alterations like deletions and duplications. The objectives of the program is to actually, as I said, we want a program which is easily translatable to the patient care. We want a program which is sustainable. We want a program which actually help people to understand ophthalmic genetics, to understand the interpretation, more interaction with genetic counseling. This is not a separate process from the actual testing itself. Provide comprehensive registries create a tissue in a DNA bank where scientists can benefit even in the future out of that. So we're looking for sustainability and translation to patient care. Cost effectiveness, we did, cost is an issue now. And basically, we do not want an operation like you spend millions, like other hospitals, they spend millions, but the actual outcome of their project is very little on the patient care. Honestly, I'm not fond of these types of programs. I like a program which is very cost effective, sustainable, and much cheaper than anywhere else.
I think the whole questions appeared. So for the sake of the time, we can just let the audience answer them.
Yeah.
If you can read the whole question. Yeah, thank you.
Yes, I can, yeah.
Thank you.
But that's the last slide anyway, so.
It's okay. Yeah, let's just obtain the reply on these poll questions, yes. So the audience can vote. Okay. So you want to comment on the answer?
Yeah, I think optineurin and mycilin are more with primary open-angle glaucoma, POAG, familial cases. And the second answer, no, it's about 0.4% because retinoblastoma is an autosomal dominant. Let's say the mutation is 100% penetrant. That means any future child will have 50% chance of inheriting the affected allele. And basically, so the answer will be 0.4 because it's going to be, we said that the penetrance for the mutation is 80%. So half of that is 0.4 or 40%. So the correct answer is number B for the second questions. And the best answer is actually E for, for the first questions. I mean, I thought the questions are very easy, but I don't know. Okay, anyway. So thank you very much, everybody. If you have any questions, I'm happy to answer.
So now we'll move on to the next speaker, Professor Angten. He's gonna present for the second time. And for those who didn't attend the first session, he's the Executive Director at the Singapore Eye Research Institute, and he's going to speak about the approach to investigating the genetic basis of disease, importance of link with clinicians. Stay tuned.
Oh, thank you so much.
And go ahead, please, and share your screen.
Thank you. So today, my next talk is really aimed at the clinicians and to talk about how we can help out in not only discovering the genetic basis of a disease, but how we can work out what the genes do and how we can help our patients. So when you suspect a disease to have a significant genetic contribution, so for example, they may have an early age of onset, there could be some enrichment in one of the sex, it could be enriched in some ethnic groups, of course, strong family history, these are all important factors. Now remember, why do we want to study the genetics of a disease? Of course, our primary aim is to help our patients. We want to understand by knowing the gene involved, we can help in genetic counseling, as well as looking at the genotype-phenotype correlations to help the patients in terms of the disease cause and the likely prognosis. Knowing the gene involved will also help us understand the disease biology. We want to know how the gene is involved in the pathways and how it can cause the disease phenotype. Of course, we also want to know if there's any role in screening or early detection, as well as whether we can develop new treatments based on the genetics of a disease. So these are all reasons why clinicians can be interested in knowing the genetics of a disease. Let's start off by something very basic and how we investigate first families with inherited disease. And I'm sure some of you will encounter these families in your practice. So if you look at the families, of course, you should look at the age of onset of a disease, look whether they predominantly affect sex. And finally, we want to know if these individuals who are affected share a part of the DNA with each other and that which unaffected individuals do not share. So that's the basic concept of trying to find the genetic basis of a disease. And of course, in the older days, we will use a linkage analysis. And this means that you're trying to link genes in the genome by running markers to see where they share common genetic contribution. And for such familial approaches, you need large pedigrees. And remember, you need to study both affected people as well as unaffected people. And you need to study the parents and siblings. So the more people you can study, the better. So don't just study affected people, but you also need to study unaffected people because you want to compare cases versus normals. Of course, as you heard from a previous speaker, Dr. Arno, we also can do a whole exome sequencing and whole genome sequencing, but these approaches are more expensive, which is much more data to analyze, and you need to have the capability of doing this analysis. It's not easy to look at whole exome or whole genome sequencing data. But the principle is still the same. Whatever method you use, you're trying to determine whether a genetic marker is shared within individual affected by a disease, and where they're not, they shouldn't be affected, and unaffected individuals should not have the same marker. So this is the basic principle. In linkage analysis, there's a statistical way of, and it's called the log score or the logarithm of odds that a region is linked to a disease. And for linkage, there's a minimum cutoff of 5 to show statistical significance. So it's not 0.05, but it's 3 times 10 to the power minus 7. An example here is the linkage analysis from a family with breast cancer or due to the BRCA1 mutation. And you can see here, the log score is more than 25, showing the overwhelming importance of this gene in that family. Now, if you go to the example of open-angle glaucoma, here is a familial open-angle glaucoma. This is the old linkage study published in 1993, where they linked the region to chromosome 1. And it took another 4 or 5 years to identify finally the gene mycilin that was in that family. So that's how you do first. You do the linkage to identify the region, and then you find the gene. Since then, many genes for open-angle glaucoma have been identified, but can you use such a method to study, for example, genetics of AMD? Now, if you look at this paper from 2005, they did multiple scans of AMD families, and they studied several hundred families, several thousand families. And after all the studies, they looked at all the results, there was no clear results. And they could not find a major gene from linkage of families of AMD. And why is that the case? Well, AMD is generally an age-related disorder, so it's not as penetrant like familial forms of breast cancer. And so the extent of sharing of particular genetic risk factors is low. And so for such diseases, it's more important to look at association with alleles rather than mutations. And usually they don't occur together. So for most adult onset diseases, you are looking more at genetic susceptibility or genetic risk factors, and you're not looking at mutations or causative genes. And here you're looking at the contribution of multiple adult onset genes to the overall disease risk. And each of these genes contribute a little risk to finally get for the patient to develop a certain disease. And so think of it like you're asking yourself, why did somebody get a lung cancer? So there are multiple factors why somebody could get lung cancer. They could be, for example, genetic risk factors. There could be environmental risk factors. There could be age and other influences. So in most adult onset diseases, the genetic effects are modest and the alleles show association only. And so because of the modest effect size of these genetic factors, you need really large sample sizes to determine these factors. And here we do a genome association studies and not linkage studies. So for the last 15 years, we've been using the approach of a genome-wide association study, also called a GWAS, which looks at running markers across the genome of many people. So usually thousands of people, and you have to run usually about at least 500,000 to 1 million markers. And these markers are across the whole chromosome, all the chromosomes. And the output is displayed in this picture called the Manhattan plot. And the Manhattan plot is named because each of these things look like the towers of Manhattan. They're like tall buildings. And each dot represents a marker or polymorphism. And you can go from chromosome 1 all the way to chromosome 22. So you can see by color here, chromosome 1 in the red in the left-hand side, all the way to chromosome 22. And the more stronger the association, the taller the Manhattan building or the taller the tower. So this is how you interpret a GWAS scan. And the GWAS is an approach to find low penetrance common genetic variants that contribute to complex diseases, for example, glaucoma or AMD. And you're looking for genetic risk factors and not mutations. As I said earlier, you need a lot of patients usually, and typically the odds ratios or associations are very low, typically below 2.0. And in order for statistical significance, the p-value is 5 times 10 power minus 8. So this is the p-value of significance that is used for GWAS studies. And GWAS can be used both in looking at case control studies, that means comparing affected versus unaffected, or it can also be used to study quantitative traits, for example, height, LDL cholesterol, IOP, etc. This is what a GWAS chip looks like. It's basically, and this is the genotyping platform that we use commonly. And the first ever GWAS for any condition in the body was actually described in the eye for age-related macular degeneration. And this was in 2005, where a case control study of only 96 AMD cases and 50 controls was sufficient to identify the CFH or complement factor H gene that was associated with AMD. And this is because it has quite a strong effect size. There are many consortiums or consortia around the world now. For example, the IGGC is the one I'm involved in for glaucoma, looking at primary open-angle glaucoma, as well as quantitative traits related to glaucoma, example, intraocular pressure, optic disc size, or cup disc ratio. And recently, in last year, they published a largest GWAS where they identified more than 100 genes for intraocular pressure and almost 70 new loci for open-angle glaucoma. For angle closure glaucoma, my group in Singapore has been involved in several GWASs. We first performed in 2012 our first GWAS of angle closure glaucoma, where we identified 5 genetic risk factors. And in 2016, we had a very much larger study, over 10,000 cases and 20,000 controls. We identified another 5 genetic risk factors. And of note, the Saudi Arabia, including KKESH, was involved in the study. My group is also involved in GWASs of exfoliation syndrome. And the LOXL1 is a major gene identified from a GWAS in 2007. And our group has identified since 2 other GWASs, one in 2015, where we identified a gene called CACNO1. And in 2017, again, KKESH was involved in a large GWAS of more than 36 countries, where we identified another 5 genetic risk factors for exfoliation syndrome. And this study included my colleague Khalid Abu Ameru, who just spoke earlier just now. Now, there are some issues with GWASs. Firstly, as I said earlier, the effect sizes are usually very small, and so you need large sample sizes. The smaller the effect size, the larger the sample size you require. The second issue is that the phenotype is very important. How do you define a patient with a disease versus who is normal? So if you get the phenotyping wrong, you could affect drastically the results of a GWAS by poor phenotyping. Another problem with GWASs is that often it's an association signal and it's a surrogate of the functional gene. So just because you find a GWAS signal, it doesn't mean that that particular gene is the gene responsible for the disease in that patient group. It could just be a marker of around the region where the actual gene may lie. So it's often just a functional surrogate. As previous speakers have mentioned, we have now moved away from GWAS, and currently the technology is whole exome sequencing. Even for complex diseases, we are looking for mutations, rare mutations of high penetrance and high risk that are often missed by GWAS. And whole exome sequencing, they do hybridization, DNA fragmentation and hybridization. And this is the method where you sequence all the parts of the exome only and not the introns. And here we're looking for something called a burden test. We're looking for non-synonymous variants. Excluding non-synonymous variants, we're looking for rare variants that are more common in affected individuals compared to controls. And currently we are embarked on big whole exome sequencing experiments in Singapore, looking at both angle closure glaucoma and exfoliation. And really we have found some very interesting findings, which we have not been to publish. But this will soon be revealed, where you will find that there are interesting variants of high odds ratio that are affected with the disease in both forms of glaucoma. And this example, for example, for AMI, where you found mutations in LDLR, which carried 13-fold increased risk of AMI. Now, sometimes a GWAS study can overlap with a rare variant exome study. And this example of AMD, and you can see here the GWAS of AMD, the towers of Manhattan, remember, and one of the GWAS hits, TMP3 on the green arrow, was also found by exome sequencing to be associated with high risk of AMD with rare variants, causing a big effect size of more than 1.3, more than 30 times, sorry. And just showing you that sometimes you can have overlap of GWAS and whole exome sequencing. Now, Dr. Arno has also mentioned about whole genome sequencing. And here we're looking at the complete genetic architecture, including regulatory regions, exons, and splicing variants. But this is still quite costly still at the moment to do on a large scale for complex diseases. But certainly it's useful for inherited diseases. So let's go on to the last part of my talk. And what is the important role of clinicians? Clinicians like you in the audience. As I said earlier, your role is very important because phenotyping is extremely important in any genetic study. You need to make the objective measurements. You need to distinguish normal versus affected. And if you get this wrong, you will get all the genetic studies wrong. You should look for the gold standard in diagnosis and use good genotyping and phenotyping methods. And you've heard earlier many examples of the importance of clinicians in looking at genotype-phenotype correlations. And once you know the disease gene of in a particular family, you can look at these genotype-phenotype correlations, which are very important for your patients to understand both the disease cause as well as the prognosis. Patients will know, for example, in advance if they have carry certain mutations, which has very poor prognosis, and sometimes you may need to do earlier surgery, for example, to reduce the severity of a certain mutation. Clinicians also have to compare genetic risk factors versus traditional risk factors. We have to weigh which of these factors are more important And does genetic risk factors improve the prognosis or the ability to detect risk of a disease? And just like there are many phases in drug testing, there are also phases in testing the relevance of a biomarker. In particular, once you prove the proof of concept and the association, clinicians have to look at incremental value, clinical utility, as well as cost effectiveness. And you have to move beyond associations to look measuring incremental value and clinical utility. So what do I mean by these terms? So incremental predictive value means, does this new genetic test have predictive information over and above established risk factors? And clinical utility means, how often does the use of this new genetic test change an individual risk sufficiently to move the patients across a critical risk threshold or therapy that's required? And for example, if you look at the example of type 2 diabetes, you can see that genetic information alone was not as useful as looking at traditional risk factors such as age, BMI, or sex. I will not speak to you about the importance of genetic counseling, genetic testing. This has been covered by many other speakers, but for clinicians or scholars, we also have to look at the role of genetic screening, and we have to look and decide whether genetic screening is cost effective and who would pay for such genetic screening on a larger population scale. So these are all important questions that clinicians have to help answer. Finally, we can help answer the role of the gene in understanding the disease biology. How is the gene involved in the disease, the mechanism of action, the pathways, as well as how it's correlated with the disease phenotype. And my particular interest is trying to determine if genetic findings can be translated into new drug targets. And especially with exome sequencing now and whole genome sequencing, it's likely that genetic findings can result in new drug targets. Let me share for you one example, and this example of LDL cholesterol. And we know that mortality from ischemic heart disease is associated with higher LDL cholesterol. And here's an old study of 1994 showing you that the use of statins reduced the incidence of mortality from ischemic heart disease because of a lowering of LDL cholesterol. If you look at the LDL GWAS, and there have been several done so far, you can see here several of the Manhattan towers that have been found from LDL cholesterol GWAS. And interestingly, you will find the statin target, HMG-CR here, with the odds ratio of only 1.1, showing you that on a GWAS hit, it is not a very major effect size, but we know the importance of statins in reducing cholesterol and how statins have now become a billion-dollar drug worldwide. Interestingly, a new target has also been discovered from genetics, and this is PCSK9. Again, in the GWAS of LDL, PCSK9 is only has an odds ratio of only 1.06, but PCSK9 was identified in families with low lipid levels. So there were many families around the world where they have very low cholesterol levels, and they never get heart disease or heart attacks. And the reason why is because they found that these families have rare variants in this gene called PCSK9 that protect them against hyperlipidemia. So basically, when they have these mutations, they cannot process the cholesterol, and cholesterol will never be raised in their bloodstreams. And so they can eat a very high-fat diet and never get high cholesterol and never get ischemic heart disease. From this discovery, pharma companies have developed drugs that mimic the effect of these mutations, in particular antibodies. And such antibodies have now been FDA approved, and there are a couple of them have now been FDA approved, and these are PCSK9 inhibitors. So in the future, in fact, now in America already, if you are resistant to statins and your cholesterol remains high, the next drug of choice is a PCSK9 inhibitor. And these are given by injections once a week or less frequently, and not a daily medication. So it just shows you the power of genetics in discovering new drug targets. So in summary, I've described to you as simply the several approaches to investigate the genetic basis of a disease. First, you have to decide, is it a familial Mendelian disorder, or is it a more complex disease? And there are different approaches, whether you use GWAS, whole exome sequencing, whole genome sequencing, or linkage analysis. The role of the clinician is very important. We play a very important role in phenotyping. We have to look at the genetic markers we find, whether you can apply them for screening or testing. You can help understand disease biology and pathways. We can help work out new targets for therapy and apply them to our patients so that their lives will be improved. And so get the fundamentals right. Remember, these are the important questions. Can we more accurately diagnose a disease? Can we more accurately define a clinical condition? Can we predict the disease or risk of disease in a patient's life earlier? Can we understand who is more susceptible to the disease and why? Can we work out new drugs and new therapies from genetic findings? Remember, we apply our research to help our patients. And as Dr. Khalid was mentioned in his last talk, it's very important to do applied research in an institute like KKESH. And I'd like to stress again the importance of collaboration and friendship. I've been very fortunate to be involved in many different collaborations from across the world. And particularly, I'd like to thank my collaborators at KKESH for their role in studies related to genetics of both angle closure glaucoma as well as exfoliation syndrome. I'd like to acknowledge my colleagues in Singapore, Dr. C.C. Kaur and Irangutana. They're both brilliant geneticists who have helped me greatly in my career. Thank you for your attention.
Thank you, Dr. Ong. I think your question is on the screen.
Yes. So the first question is, when would you suspect a disease to have a significant genetic contribution? So A is early age of onset, B is strong family history, and C is enriched in either sex, and D is all of the above. So please answer the question. And the next question is on genome-wide association studies, or GWAS. And the options are: 1, they require many pedigrees of affected individuals with family members. 2, involves DNA sequencing. 3, are helpful in studying the genetics of exfoliation syndrome. And 4, the p-value of significance is 0.05. So please answer the questions. So can you go to the results?
Yeah, let's see the answers.
Okay, so you're right. It's all of the above. And the second one actually is wrong. It's C. It's helpful in exfoliation syndrome. So remember, it's a complex disorder. And so GWAS studies are helpful. They're not so helpful in pedigrees with Mendelian disorders. So those are different approaches. Thank you for your attention.
Thank you so much. So we're going to move to our next talk. It's going to be presented by Dr. Patrick Schatz. He's a senior academic consultant in the Vitreoretinal Division at King Khalid Eye Specialist Hospital. He's also associate professor at the Institution of Clinical Sciences Ophthalmology, Lund University in Sweden. He joined KKESH in 2014. Very interested in genetic origin with many publications since he joined us. He's going to be talking about clinical assessment of patients with RPE65 retinopathy. Thank you, Dr. Patrick.
Thank you very much, Dr. Bakri. Thank you to the program committee and to the CEO, Dr. Abdulaziz Al-Raji, for letting me have this talk. Let me share the screen. Okay, can you see my screen?
Yes, it's clear.
And you can hear me, good. Thank you very much. I don't have any financial disclosures. as far as we know, we have at least 19 patients in KKESH with biallelic mutations in RPE65. Does this mean that they all have the same disease? And does it mean that they can all have subretinal gene therapy? Well, in order to maximize the chances of any benefit from subretinal gene therapy, we need to make sure that they have the correct diagnosis and that they are eligible for gene therapy by using these methods. Key to understanding this disease is the vitamin A cycle. When, when there is a reduced flow through the vitamin A cycle, we get a reduction of the rhodopsin, and there is also a reduction in the buildup of autofluorescent fluorophores in the retinal pigment epithelium. And this explains why these patients have a reduced fundus autofluorescence. Note also that there are several genes involved in the vitamin A cycle. And when there is a disease in any of these genes, there will be a reduction in the fundus autofluorescence. Also important here is the concept of hypomorphic mutations, which Dr. Rola, she also mentioned. Hypomorphic mutation means that there is a reduced gene function, but it's not completely abolished. And this can explain some of the differential diagnostic considerations and some of the phenotype-genotype correlations, as we will see further on. Already in 2004, Dr. Birgit Lawrence and her co-workers, they noted that the fundus autofluorescence is reduced in patients with biallelic RPE65 mutations. A bit simplified, in the normal situation, we have a dark disc and a bright fundus, whereas in biallelic RPE65 mutations, we have the opposite. The disc is bright and the fundus is dark. So can we use fundus autofluorescence as a screen retinal dystrophies in order to try to find the patients who could have any benefit from gene therapy? As on the right hand of your screen, you have a patient with biallelic RPE65 mutations, and on the left hand, we have undiagnosed retinal dystrophy. And let's see how good the autofluorescence is. Now you see here the pattern is different, and also it turns out to be a different disease. Again, different pattern, different disease. Not the same pattern, it's another gene again. Again, we have a different pattern and it's a different disease. What about this one? Here we also have like a bright disc, but the reduction in autofluorescence is not as homogeneous. And again, it's a different disease. This one, okay, we have a bright disc and a dark fundus. It could have been RPE65 mutation, but it turns out to be another gene, which is also involved in the vitamin A cycle. So fundus autofluorescence is very useful. It's if we have this pattern, it's very likely to be RPE65 mutations, but there are a few other differential diagnoses, mainly those genes involving the vitamin A cycle. Again, a reminder about the vitamin A cycle. It's fundamental for understanding this disease. And as I mentioned, there are also other genes. This is a case of fundus albipunctatus, which is classically associated with mutations in RDH5, another gene involved in the vitamin A cycle. It's characterized by the white dots in the fundus, similar picture in the autofluorescence. Sometimes there is a reduction in the central retinal thickness with almost like cone dystrophy appearance. And these are the outer retinal deposits, typical of fundus albipunctatus. And to prove that it is fundus albipunctatus, we need to do a special type of ERG with prolonged dark adaptation. Typically, there is a recovery of the ERG with prolonged dark adaptation. And this is different from the typical patient with biallelic RPE65 mutations. They typically have a flat ERG, no response. And again, there is a concept of hypomorphic mutations in RPE65. Certain mutations in RPE65 can indeed lead to fundus albipunctatus picture. And here is such a case. This is a patient with biallelic RPE65 mutations, but he has a mild disease and the fundus albipunctatus phenotype. And it's important to recognize this because the disease is mild and gene therapy might not be indicated because it also is associated with certain risks. And here we would need to do a prolonged dark adaptation ERG in order to prove that this is fundus albipunctatus. This is more the typical patient with biallelic RPE65 mutations, not the widespread retinal degeneration, but the relatively well-preserved retinal lamination in the center, and the ERG is non-recordable. These patients also have nystagmus and night blindness typically. If we give them subretinal gene therapy with RPE65, their dark adaptation improves, and we can measure this with the FST. The visual fields might also show some improvement, but we need to be aware of that there might be a degeneration, transient degeneration of the outer segments. This is probably induced by the retinal detachment, and there is a potential for recovery with time, at least a partial recovery. This is known from animal experiments of induced retinal detachment. Back to our cohort in KKESH, these are some of the characteristic findings in this cohort. They all had their onset in early age, either since birth or early childhood. They have a well-preserved central macular thickness, and in that sense, they could all potentially be candidates for gene therapy. One of the patients, though, had fundus albipunctatus, and another patient had end-stage keratoconus. Thank you for your attention, and during the next talk, Dr. Suleiman will go more into our experiences with the gene therapy. Should I proceed with the poll?
Yes, please, go ahead.
So the first question is, which of the following clinical tests is most useful for assessment of eligibility for gene therapy in patients with retinal dystrophies? And I was referring to undiagnosed patients with retinal dystrophy. Is it OCT, optical coherence tomography? Is it fundus autofluorescence, or is it full field ERG? Next question. Which is the most likely cause of loss of the foveal inner segment ellipsoid zone shortly after subretinal gene therapy? Is it degeneration of the photoreceptor outer segments due to the induced retinal detachment? Is it drug toxicity, or is it a poor surgical technique? Okay. The first question, the correct answer should be fundus autofluorescence, because it's very specific test for biallelic RPE65 mutations. It of course needs to be confirmed with genetic testing, but there are just a few other genes which can lead to this typical picture with the generalized reduction of the fundus autofluorescence. The correct answer for the second question is, as most of you also answered, is that it's associated, the loss of the outer segments is due to the induced retinal detachment. And this may also recover to some extent with time. Thank you.
Okay. So KKESH was the first center outside North America and Europe to perform the first FDA-approved intraocular gene therapy, Luxturna, for the treatment of RBE. And it's my great pleasure to introduce one of the Luxturna team in KKESH, the retina surgeon, vitreoretina surgeon, Dr. Sleman. He's currently working as an associate, also director of fellowship and residency program in KKESH. He has a degree in pediatric retina from Illinois INU Infirmary from Chicago, and he's going to present the KKESH RP65 experience. Dr. Sleman.
Thank you, Dr. Samar. It gives me a great pleasure to share with you the results of the first patient treated with Luxturna gene therapy here at KKESH. I have no relevant financial interests. Before I go ahead with our patient, I would like to acknowledge the following. First, the scientists and researchers who participated and who worked hard to have this treatment available for our patients. Also, the patients who contributed in the early clinical trials and for their courage. Our government, represented by the Ministry of Health, which strives to deliver the best medical care possible for our patients. And to KKESH for KKESH administration for their work to overcome many of the obstacles to have this medication available in the kingdom. In fact, this subretinal gene therapy treatment was performed in Saudi Arabia, and it is one of the first few countries in the world to have this treatment. So our patient is a 30-year-old female with nyctalopia and progressive loss of vision since early childhood. She has two older siblings with the same condition with advanced disease, which makes her able to see what the future holds for her. She was diagnosed with RPE65 related retinal dystrophy due to homozygous variant of RPE65. She had the baseline vision of 2200 in both eyes. And the anterior segment examination was remarkable. You can see the fundus appearance in both eyes. And this is the autofluorescence. Dr. Chats described it very nicely. And this is the OCT in both eyes. She has a reasonable retinal thickness with good lamination of the retinal layers, which makes her a good candidate, at least structurally, for treatment. This is her visual fields in both eyes, and it is showing restriction in both eyes. FST which is full field light sensitivity threshold testing, is a measure of visual function generally assessed per eye, and was chosen to test the underlying physiologic function of the rod photoreceptors predominantly affected by the RPE65 mutations. FST is measures the lowest illumination perceived over the entire visual field, and the meaningful change has been suggested as 10 decibels. This is how the report comes. If you see this rectangle, this is the value of this patient, of this particular patient, and this is the mean value for normal population. And this is how the machine looks. So in our patient, she had minus 0.65 decibels in the right eye and 3.6 decibels in the left eye. She underwent surgery in both weeks, in both eyes, with a few weeks period in between. You will see, I will not go into details of the surgical procedure, but you can see here the delivery of the subretinal drug with the blip formation. We usually deliver 300 microliter of the drug in the subretinal space. You can see the blip in one eye went downwards, and in the other eye it went upwards. It is variable, and it is not something that the surgeon could control 100%. So the patient had an uneventful post-operative course. She noticed improved light sensitivity and dark adaptation. She can see better at night. She says that when she moves from a dark room to, from a well-lit room to a dark room, she doesn't have the problem with the dark adaptation as before. In fact, she complains of excessive glare during daytime and blurry central vision in the right eye in the early post-operative period. This is her pre-operative OCT of the left eye. This is at 10 days, and this is at 1 month. You can see the restoration of the retinal layers. This remained the same at 2-month follow-up. This is the right eye, and you can see this is at 10 days. And at 1 month, still she has some ellipsoid zone changes. Unfortunately, we were unable to see her afterwards because of the COVID-19 issue, but hopefully she will be coming in the near future for follow-up. Her visual fields, you can see that she slightly improved in the right eye, but the left eye showed significant improvement. And in the FST testing, she improved from minus 0.65 decibels in the right eye to minus 35 decibels in the left eye. Sorry, minus 35 decibels, and in the left eye, 3.6 decibels to minus 33 decibels. So this is the beginning. Hopefully, with the patients that were presented by Dr. Chads, we can deliver treatment to them in the near future. You can put my all questions now. So the first question is, all of the following parameters may improve with RPE65 gene therapy except A, visual field, B, light sensitivity, C, visual acuity, D, retinal thickness on OCT. And the second question is, which of the following is most likely to improve with RPE65 gene therapy? A, visual field, B, light sensitivity, C, visual acuity, D, retinal thickness on OCT. Still, we are learning about this medication, but so far, you can put the answer that you think is the most likely correct answer. So the first question, the answer is correct. Retinal thickness on OCT is not likely to improve. Visual acuity may improve based on the phase 3 trial. Light sensitivity is the most likely to improve based on the study. Thank you all for your attention. I know it's not easy to stay that late, but thank you all, and hopefully we can see you in the near future. So the question is, what the RPE gene therapy was discovered since 2017. Why did we wait until 2019 to make it available for patients? This is a good question. It has become available internationally commercially in 2019. And in fact, we are the first country in the Middle East to, at least in the Gulf area, to deliver this treatment to our patients.
So at the end, I would like just to say to all the speakers, dear speakers, I appreciate the time and energy you put on your outstanding presentations and answering all the questions on time. Dear organizers, thank you for coming together as a team and making this event possible. And the research collaborators and participants, it was an amazing event. I would like to thank you so much for this wonderfully lively interaction and for your kind attendance during weekend. Kindly don't forget to fill up the evaluation form, which you're gonna receive at the end of the symposium to get the CME hours. And you will receive also the certificate of attendance. We're eagerly awaiting to meet you either physically or virtually in our next educational activity. Stay safe and enjoy the rest of your weekend. Thank you all.